Masih Pak, ini sih. Apa? Oh, ya. Siapa? Siapa? Mulai dari negas masuk apa Isya gitu.
Ini kamu share kan ini lah. Abi mau bisa share. Ini integrative approach-nya. Kamu lebih nengan kok.
Ini mesti belum. Jadi
Kelas gitu ya. Yang di belakang juga boleh maju ya teman-teman, kakak-kakak, bapak, ibu. Terima kasih. Shortly, we will begin the guest lecture and please everyone have your seat. Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh, Shalom Namo Buddhaya, and best wishes to all of us. On behalf of the Faculty of Medicine, I would like to extend our warm welcome all of you to the event. The Honorable Dean of the Faculty of Medicine Udayana University that represented by the Vice Dean for Academic Affairs and Planning of the Faculty of Medicine Udayana University, Dr. Medical Dr. Igede Eka Wiratnaya, Orthopedi and Traumatology Specialist Consultant. Our guest lecturer, Director Tobacco Control Vital Strategy Singapore, Mr. Tara Singh Bam, MPH Ph.D. Today's responders from Health Administration Associate Expert Member of Tobacco Related Disease Control Working Team, Mrs. Hanifah Rongayah, Bachelor of Public Health and Master of Public Health, Expert Epidemiologist Tuberculosis Working Team, Ministry of Health of the Republic Indonesia, Dr. Medical Dr. Rina Handayani, Master of Health, Asia Pacific Cities for Alliance or APICAT Media and Citizens News Service or CNS Editor, Mr. Bobby Ramakant. Our respected Head of Department of Public Health and Preventive Medicine, the Faculty of Medicine Udayana University, Dr. Medical Dr. Ketut Suarjana, Master of Public Health, as also our moderator for today. Coordinator of Public Health Undergraduate Study Programs, the Medical Faculty of Medicine, Udayana University, Medical Dr. Putu Ayuswan Dewi Astuti, Master of Public Health, and Ph.D. official from Bali Provincial Health Office, official from Denpasar City Health Office, official from Port Health Office, all study program coordinators within the Faculty of Medicine Udayana University, representative from health education institutions in Denpasar City, and all participants who attend the guest lecture both online and offline. Once again, welcome to the Public Health International Guest Lecture Series 2025, Integrative Approach to End the Double Burden of Tuberculosis and Tobacco Use. This guest lecture proudly presented by School of Public Health, Faculty of Medicine, Udayana University, and supported by Udayana Central Center for NCDs, Tobacco Control, and Lung Health. Udayana Central is a research and advocacy center focused on public health issues, including non-communicable disease, tobacco control, and lung health. The center conducted researchers, advocacies, and capacity building for tobacco control, tuberculosis, and other public health problems. Several notable achievements. One, the adoption of provincial smoke-free law in Bali as the first provincial law in Indonesia, followed by districts smoke-free law across Bali. The adoption of tobacco advertising regulations in Bali. National survey on tobacco control, smoke-free law compliance, air quality monitoring, evaluation of smoke-free implementations, cigarette price monitoring survey, and many more. Before we start the agenda, let's start these sessions by praising the God with prayer. Prayer are held according to your respective belief. Okay, let me lead the prayers one. Let's begin our prayers. Okay, everyone, thank you. You may have finished your prayer. Ladies and gentlemen, next agenda is opening remarks for Medical Dr. Putu Ayuswandewi Astuti, Master of Public Health, Ph.D., Coordinator of the Public Health Undergraduate Study Program, the Medical Faculty of Medicine, Udayana University. We're pleased to welcome Dr. Ayu on the stage. Dear Dr. Ayu, time is yours.
Cek. Okay. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, nama budaya, salam sejahtera untuk kita semua. Our honorable guest lecturer, Dr. Tara Singh, Director of Tobacco Control Director, Vital Strategy Singapore Office. Honorable Vice Dean of Academic Affairs and Planning, Dr. Eka Wiratnaya, Orthopedic Consultant. Head of Department of Public Health and Preventive Medicine, Dr. Ketut Suarjana. Representative from Ministry of Health, from the Tuberculosis Working Team, and also from the Tobacco Control Related and Tobacco Related Disease Working Team. Representative from Asia Pacific City Alliance for Health and Development media partners, who will serve as commentator for today's lecture. And representative from Bali Provincial Health Office, Denpasar City Health Office, also from the Health Port Office in Denpasar. Representative from the health institution across Denpasar who attend the meeting today, and also all the students. Students from all the bachelor degree at the Faculty of Medicine, and also I think from the medical profession also coming. And all the participants and guests that attended the lecture today, both offline and online. It is our honor and privilege to have Dr. Tara Singh, who have very vast experience in managing and supervising tobacco control and other related health program across Asia Pacific. Actually, Dr. Tara has been supporting and also mentoring us here at Udayana. So our team at the Udayana Central has been working since 2010. I believe I met Dr. Tara for the project management training in Lombok back then in 2010. So it's been 15 years now. So we have been collaborating on all tobacco control activities and advocacy around Bali and also in Indonesia and regionally. And so it's our privilege and pleasure to have you here again. Welcome. I think it's also your home now, Diana. And this today's guest lecture is in relation to the commemoration of World TB Day, which is celebrated every year in the 24th of March. So it's as a reminder that tuberculosis is remain cases in the world. So, and we know that tobacco use is one of the predictor or determinant of tuberculosis, and tobacco smoking is also prevent and halt the cure of the tuberculosis patient during the treatment. So since right now Indonesia has both of the problem, it's become a dual burden. I think discussing this issue is really important to us to see what we can do to address both the tuberculosis problem and also tobacco use in Indonesia. Right now, tobacco use is also very worrying since there's an increase of prevalence among young people, which in the future has become another health burden. So I would like to extend my gratitude to Dr. Tara and also all the participants for coming here today. So we hope that we have a fruitful discussion, lesson learned to be shared. Please feel free to ask questions in Bahasa or in English, so as much as you can, so we can discuss. And if there is outstanding question, we can obviously will convey the question and give back the answer to you later on. So on behalf of the School of Public Health, I'm also, if there's any issues regarding the meeting, I sincerely apologize for that. So hope the lecture today will run smoothly and we get all the benefit from today's lecture. I would like also to thank the team from the School of Public Health and also from Udayana Central to prepare this lecture in quite short time, and thank you for all for coming today. Hope you enjoy the guest lecture. Om Santi Santi Om. Wassalamualaikum warahmatullahi wabarakatuh. Shalom, nama budaya, salam sejahtera untuk kita semua.
Thank you, Dr. Ayu. Ladies and gentlemen, our next agenda is opening remarks from Dean of the Faculty of Medicine, Udayana University, that represented by the Vice Dean for Academic Affairs and Planning of the Faculty of Medicine, Dr. Medical Dr. Igede Eka Wiratnaya, Orthopedy and Traumatology Specialist Consultant, and will also open today's event. We are pleased to come Dr. Medical Dr. Igede Eka Wiratnaya, Orthopedy on the stage, and Dr. Eka, time is yours.
Good morning, everyone. Yeah, of course, I would like to say our greeting first. Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh. Salam, salam sejahtera, nama budaya, salam kebajikan, salam rahayu untuk kita semua. Honorable guest speaker from Singapore. He is the director of Tobacco Control Asia Pacific in Singapore. I call Mr. Tara Singh Bam. If I'm wrong to spell your name, sorry. There's and then of course coordinator study program from public health, undergraduate public health, Dr. Ayu Suwandewi, she's my friend. And of course, head of department of public health, Dr. Suarjana. And I hear some part of honorable guest invitation today here is from a healthy province office. And I think from, I heard about media. I don't know exactly what's media comment, something like that. Yeah, yeah, thank you so much. You attend the meeting today. And of course, to all participants here, and especially for the committees to have a very big effort to make the meetings very well. Thank you so much for supporting this meeting today. And of course, we apologize because our dean is not here, or the other meeting. And hopefully, I can give a small remark. It's not very long remark, Mr. Tara. And that's really important we understand what tobacco, tobacco, and of course, and tuberculosis. This is our problem in Indonesia, and specifically, particularly in Bali. I think we still have a lot of problem with tuberculosis, especially when you know that a lot of this is like immunocompromised. This is from HIV, something like that. And we have now that tuberculosis is becoming higher. And then the other one is, of course, the double burden. It's very good, what's called term in this meeting today, because double burden is mean we have burden some part from tuberculosis and some part from tobacco. This really, what's called, reinforce something like that, the burden for our lung to be one of a health problem in Indonesia and especially in Bali. That really, what's called, grateful to you, Mr. Tara. You come here, give a lecture to our student here. And I know you regularly come to Bali. I think I think the Department of Public Health invite you many times come to Bali. I met you in the, I think the last time in a what's called anniversary, right? The anniversary of public health. Yeah, the last time I talked with you. That's really interesting. Then in the future, hopefully you make strengthen our collaboration and bring your resource, especially human resource, your friend, your colleagues come to our Faculty of Medicine and University of Udayana University, and then we can make a lot of things here. And sometimes you can invite some of our our lecturer come to you and maybe make a research collaboration, and some part maybe we can like education in your country. This is really important for us because we live in the same region and we can do a lot of things for our region here in Indonesia and southeast of a country. And I don't want to give a lot of time, but take a lot of time for the, I think very important you give a lecture, then I talk here, right? And then and really appreciate, once again, really appreciate you come here and all the participants come. Please, you can learn a lot. You can give a lot of questions to Mr. Tara and all speaker here. And then hopefully you can open your mind and have a lot of things in your mind and can fix the problem, especially in our province in Bali. And thank you so much once again to all of you. And just because the committee would like to open the meeting, I would like to say the meeting with the topics integrated approaches to end the double burden of tuberculosis and tobacco use is obviously open.
Give an applause, everyone. Thank you for the speech, Dr. Eka. To Dr. Eka, please stay on the stage for the presentation of the token of appreciations to our guest speakers. I would like to invite Dr. Tara to the stage to the processions and also all invitees, Dr. Ayu, Dr. Suarjana, to accompany Dr. Reka on these processions. Give an applause, everyone. Okay, maybe one more. Maybe one more with the formal, yes. Okay, thank you. Thank you. Everyone have your seat. And now for the second session, we want to take a photo with all of the participants. So please, for all of participants, please stand up for documentations. Oke, jadi teman-teman yang di pinggir bisa merapat ya. Kita rapatkan di tengah dulu. Ke depan juga nggak apa-apa, ini masih banyak sekali, ada space supaya semuanya kelihatan ya.
Yang di belakang pepetkan ke tengah ya, biar masuk. Dia mau dibilang 1, 2,
Okay, thank you everyone. Please have your seat. Okay, now we will go out into the main session of Public Health International Guest Lecture Series 2025, Integrative Approaches to End the Double Burden of Tuberculosis and Tobacco Use, and the session will be chaired by a moderator. Firstly, let me introduce our moderator today. He is Medical Doctor Ketut Suarjana, Master of Public Health, as our moderator today. Dr. Suarjana completed his bachelor degree in medical science at Udayana University, then completed his master in hospital management at the Gajah Mada University, and completed his Ph.D. in hospital management at the Berlin School of Economic and Law, Germany. He served as head of Department of Public Health and Preventive Medicine and part of civil servant lecturer at the Public Health Study Program, Faculty of Medicine, Udayana University since 2006. And Dr. Suarjana has extensive experience in healthcare management, research, and international training, including leadership, tobacco control courses in countries such as Australia, Germany, and China. He also as associate professor in the healthy policy and administrations. His research focuses on public health issues such as compliance with smoke-free legislations, TB case notifications, and the impact of smoking on low-income communities with indexed publications spanning 2007 until 2018. He also active member of the Indonesian Medical Associations or IDI, Denpasar, and the Indonesian Public Health Associations yakni Bali. Okay, so without any further ado, please welcome our moderator today, Dr. Suarjana. Thank you.
Check, check. Okay, thank you, MC. Good morning, everyone. Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh, salam sejahtera, shalom, nama budaya, salam kebajikan, salam sehat untuk kita semua. Thank you for having me here as a moderator for our distinguished speaker for the guest lecture. First of all, maybe I would like to introduce our speaker here and also greet the audience, not only in this room but also in the Zoom. Yeah, maybe I will use the mix between bahasa and also English. Because Pak Tara, our speaker here, Dr. Tara Singh Bams is pernah tinggal di sini di Indonesia selama 6 tahun. So adik-adik dan Bapak Ibu tidak usah khawatir kalau nanti ada pertanyaan. Oke, nanti bisa dalam pertanyaan dalam bahasa Inggris maupun dalam berbahasa Indonesia. Oke. I would like also to greet the participant in Zoom meeting, and also we have a responder or commentator from the Ministry of Health, particularly from the tim kerja of tuberculosis, as well as from the NCD Directorate. Ada Ibu Rina dan juga Ibu Hanifah. Sudah join ya? Belum ya? Sudah? Belum. Ya, sambil menunggu mereka join, mungkin I would like to introduce our honorable and distinguished speaker here, Dr. Tara Singh Bam. We are truly honored to have you with us here, sir. Oh, this is already the biography ya. Mungkin saya akan menerjemahkan sedikit ke dalam bahasa Indonesia ya. Jadi Dr. Tara Singh Bam ini adalah seorang praktisi kesehatan masyarakat dan memiliki gelar doktor dalam public health dan magister di primary healthcare management. Ya. Jadi recently saat ini dia menjabat sebagai direktur di Vital Strategi. Jadi sebuah organisasi untuk global untuk public health, terutama tobacco control, dan Dewan Direktur ya, Board of Director untuk City Alliance ya di Asia Pasifik, atau mungkin aliansi kota-kota sehat ya di Asia Pasifik, disingkat S.Ked, yang berhome base di Singapura. Kemudian beliau memegang peran utama ya, peran penting, lead roles dalam bantuan teknis kepada atau technical assistant kepada pemerintah pusat maupun subnasional atau di daerah di kawasan Asia Pasifik ya. Dalam memajukan program public health dengan pendekatan One Health. Jadi beliau juga bagian ya dari WHO atau WHO sebagai anggota WHO Civil Society Working Group for NCDs. Jadi untuk kelompok kerja untuk penyakit tidak menular. Jadi beliau memiliki lebih dari 25 tahun pengalaman dalam pengembangan kebijakan kesehatan masyarakat, program manajemen, research atau penelitian dan evaluasi ya, terutama di bidang pengendalian tembakau, NCDs atau PTM, tuberculosis, HIV/AIDS, penguatan sistem kesehatan, dan One Health. Jadi semua ya ilmu public health dikuasai ya. Dia juga memiliki experience atau pengalaman mengajar dan penelitian akademis dengan banyak makalah yang dipresentasikan juga diterbitkan di jurnal peer review atau jurnal yang bereputasi ya. Jadi tepuk tangan dulu untuk our distinguished honorable guest speaker, please, sir, Dr. Tara, and join me here. Yeah. According to the schedule, we have 130 minutes actually, but I will give you 60 minutes for presentation and then 15 minutes for the responder or commentator from the Ministry of Health, both of them, and then discussion, question and answer. From Overmobi also, 3%, yeah? 10 minutes, 10 minutes, 10 minutes then. So yeah, it's enough, okay. So please, Dr. Tara will present the topic about the integrative approach to end the double burden of tuberculosis and tobacco use. Jadi ada beban ganda di TB dan juga perilaku merokok ya. Nanti kita lihat apa kaitannya dan apa strateginya. Please, Dr. Tara, the time is yours.
Thank you, Pak Ketut. Good morning. Yes. Just to clarify here, I'm not a guest lecturer, the first, and I'm not that old as mentioned in my CV. So you can see I'm wearing the same batik that you see and also in the flyer. I'm the student of the Udayana University, still learning for almost 15 years. So I'm also one of your colleagues or friends in this university. That is first. The second is the Vice Dean also mentions that is I frequently visit here and come in Bali. So it's actually Bali is my also the home is my also room as well. So I'm also the family member of the Bali. The whole we are the family member here. The third point is as I mentioned. I'm not an international. As I mentioned, I'm from Bali, right? So I'm not an international lecturer. I'm here only to learn from you about the issues that we have today. First of all, I would like to thank the Udayana University, especially Faculty of Medicine and School of Public Health for inviting me officially for this the events to share and to learn about TB and tobacco. Thanks to the Vice Dean and all the, for the participation in the openings and also providing some guidance. Thanks Ibu Ayu and Pak Ketut and all the teams for your the support and also for your continuous the efforts in public health programs in Bali and also in Indonesia and globally. And I can see so many of my colleagues here. The Kurni and the Tri, Artha and Surya and many of us, we have been working together for a long time. I'm also here with another student that is also from Nepal, is Parmila Bam. She just joined this the university. She will be also one of the friends. So with this, I would like to also the thanks and welcome to our colleagues from Ministry of Health, from the TB and also the NCDs, and we have also wonderful our media, the friends, the editor from CNS, Bobby, also there. So with this, actually, let's start some of our point that we put together here, the double burden. So I have so many questions to ask and to learn. When I ask the question, that means I don't know. I would like to really learn from you. So how many of you see still in this century, okay, TB is still, tuberculosis is still a problem? How many of you, would you mind to raise the hands? I don't see the problem. I don't want to raise the hand. How many of you? 1, 2, 3, 4, 5. So I can see, only very few of us, we know tuberculosis is still a problem in our community. I don't know. Let's discuss that. And how many of you really consider or see tobacco smoking a big problem for our community? I think some more hands than the TB. Okay. So we can see like, okay, then how many of you think like a TB and tobacco, there is some co-epidemics? They like each other, the TB and smoking. How many of you think like there is an issue of TB, there is an issue of smoking in tuberculosis? Anyone? Yeah, actually, yes, it's many. So thanks. With this, let me share some of our slides. That is not a new. It's I have put together the evidence that's published already in a WHO, by WHO or Ministry of Health or many other the researchers together. So let me show some of the slides and discuss further. Which one is? Okay. Tuberculosis. I think the TB is one of the major public health issues still in our setting. What do I mean by setting? In our setting. Where are we now? We are in Asia, right? Are we? And from Asia, especially we are in Southeast Asia, and we are in a high populated countries, that is Indonesia or India or Bangladesh or Philippines or Vietnam or any of the countries. So we have big population in our region, of course China there. So in this context, and also we see, do we have something that we can address together? That is our approach. So we are in a really good public health setting. So if you will compare the public health or primary health care, it's very different here in Indonesia, or I'm from Nepal, or in my country, or in Bangladesh, or in India, and also the different than Singapore. Singapore is a bit high income country, it's a very close settings, and they have a different types of approach of public health. We have different. So in Singapore, the TB is no more the issue of public health concern. So they are working on a different environments with a different public health strategy and the approaches. But in Indonesia or some other country, as I mentioned, India, Bangladesh, and we work differently. We have a different public health approach. That is through the primary health care, through the puskesmas, community health. We talk many about our health approaches. So there is some different approaches, different strategy if we compare with the developed country where there is no tuberculosis, like for example, Singapore in our context, or in Australia or New Zealand or Europe. And we work a bit differently in a context where tuberculosis is a big problem, for example, in Indonesia or India or any other countries. So different approaches and different strategies. So what's the main focus in TB control program? I'm sure that we'll hear from the expert from the Ministry of Health as well. The first thing that we need to do is screening. I think that is one of the key primary focus of the early screening of the in a community to find the TB. And early diagnosis and early treatment. So these are the three key things that we need to have in our primary health care or in our system. So therefore, then we can only cut the chain of transmission. So because it's a communicable disease, right? So it can be transmitted through the droplets or the, when we breathe. So we need to cut that transmission. Then we can end the tuberculosis. So that means early diagnosis, early treatment, and mass screening. Those are the key strategies. So if you look at the burden at the global level, so we have now at the global level, as per the WHO report 2024, it's a recent report that we have more than 10 million TB cases around the world, globally. Like as the Ibu Ayu mentions, the more than 60% of those TB cases in our region, especially in Asia. In a top high, and Indonesia is one of the main contributor. Like out of 10 million, almost 1 million estimated TB cases are only in Indonesia. So that means 10%, right? 10% of the global TB burden that we have in Indonesia is a huge number. So of the 10.8 million people, those who were diagnosed in 2023, and also in the same year, how many people actually died because of a TB is 1.25 million. It's a big number. It's very, very big number. If you compare to the one country like a Negara, right? Timor-Leste. What is the population of Timor-Leste? It's less than 1 million, right? Because more than 1 million people die each year because of the TB. So it's a big problem. And if you look at the statistic, the data from Indonesia, do you have any data? Do you know? Can you estimate how many people die from tuberculosis in Indonesia? It's over 100,000. It's over 100,000 TB. People die from TB each year in Indonesia. Those people, those deaths we can prevent. That's why we are here, we discuss. And I'm sure you all are public health, we are the public health people, and our goal is to save lives. To save lives. I think that's a huge problem. In terms of tobacco, it's another issue. It's a billion the smokers around the world. It's 1,133 million smokers that we have at this point at the global level. And 8 million people die due to tobacco-related disease each year. That includes tuberculosis death as well. It's a big number, 8 million. It's more than a population of Bali. Bali has 5 million something, right? So can you imagine 8 million people die because of the tobacco-related disease? It's a huge number. So if you look at the TB and tobacco, the co-infection, the burden in TB control program or burden in tobacco, TB attributable, there are, I think it's a bit old statistic, about 1 million, I would say 1 million TBs are because of the tobacco smoking globally. And about 16 to 20% deaths are because of the tobacco smoking among the TB population. People smoke, and there is an issue in terms of that impact in treatments, impact on the other aspect of the health, and the other comorbidities. So there is a huge death among the TB population because of tobacco smoking. So that's the problem that we have now. Sorry. So as I mentioned, the risk factor, there are 5 key risk factors of tuberculosis. So what are they? They are undernutrition, that we call malnutrition, the alcohol, diabetes, HIV, and smoking. So in this slide, you can see all of these issues, all of these risk factors, I think, exist in our community. Do you agree with me? Do we have the issue of alcohol? Yes. What about the HIV? Yes. Smoking? And diabetes is another big problem, the NCD. So, and there are, the very close the association between TB and diabetes, between smoking and diabetes, and smoking, TB and diabetes. So these are key 5 risk factors that we have. If you look at these are the global statistics. It's almost, it's close to 1 million, the TB burden is because of the malnutrition. Maybe it's not a big problem in Indonesia or not a big problem in other country, but this is one of the significant factors in many countries, for example, in India. I think Indonesia is also many issues. So alcohol use, maybe not a big risk factor. For example, if you look at the whole country, the Indonesia, but we can see the big consumption of alcohol in Bali. Bali is always, so it can be the risk factors can play their role as per the setting, as per the environment as well. So smoking is the 3rd biggest risk factor at the global level in tuberculosis, and then HIV infection. For example, HIV is a big the issue in Africa. Many people die because of HIV infection in TB population. So that is also something there. It depends on the setting where we are. So just to compare the risk factors, so if you can see this global, the map is only the smoking. If you look at the map here, the dark blue or purple, whatever you can see here, is a country where the percentage of the smoking, attributable to the TB is more than 15%. So in Indonesia is in that brackets. So in Indonesia, more than 15% of TB, I will show you later on another slide, is because of the tobacco smoking in our community. So compared to other countries, that's something. So you can see the global burden of smoking among in many countries in TB control. So let me show you the detail about this slide. This is only for Indonesia. Among the 5, the risk factors here, smoking is the number 1 risk factor for tuberculosis. So therefore, we talk about like if we don't control or eliminate smoking, stop smoking, it's very impossible to eliminate tuberculosis, because that's also one of the main risk factors. Of course, there are some others like the alcohol here, the HIV, diabetes, and nutrition as well. The second largest, the risk factor is malnutrition. So in terms of number, that's the same thing. So in terms of number in Indonesia, if you look at I'm sure you all are the public health, here you would like to see the data. That's why I tried to put, yesterday I discussed with Ketut, and also, whether this, slide would be interesting or not. So just, yes, he said, yes. If you look at all these risk factors in Indonesia, smoking actually is one of the key risk factors for tuberculosis, and that contributes about 150,000 TB cases each year. So if you look at in a confidence interval 95, the upper part is more than 300,000 TB disease, and the lower is at least 41,000. So it's a huge number. It's a very big number, and contributing significantly in TB epidemic in Indonesia compared to others. Of course, other risk factors, we have to also manage them through our regular services in a Puskesmas or in the TB control program or any public health intervention. Oh, sorry. Maybe what I'm doing. Yeah, this is just a number. Again, in India, the smoking is also one of the risky factors. Among, India is a huge country. They have a big number of TB there. So it's 8% of all TB cases are attributable to tobacco smoking or tobacco use in Indonesia. Sorry, in India. So if you look at in Indonesia, more than 30%. So if you look at all these high burden countries in our region, the China, Philippines, Pakistan, Bangladesh, Myanmar, Thailand, even Vietnam. So Indonesia is one of the main the countries where smoking is highly prevalent and contributes significantly to TB disease. In terms of death, that's about more on the morbidities. In terms of death, so look at all these figures here. In Indonesia, the tobacco-related, the tuberculosis-related deaths due to tobacco is about 17%. It's a big number. So if we manage to have a very comprehensive tobacco control or smoking the control program through our regular TB services, we can definitely save these lives. So this is just again the slide is updated data from the WHO. So you can see smoking, whether this in our all these countries, as I put it here. When I say the high burden countries, they are high burden in TB. They have a big problem in tuberculosis, and also at the same time the problem in tobacco smoking. So country like Bangladesh, there is a problem of tobacco smoking and also TB as well. So look at in Bangladesh, still the smoking is the second, number 2 big risk factor in TB. So in China it's number 1, similar to the Indonesia. So you can see in China many people smoke and smoking prevalence is quite high. It's not high as the Indonesia, but it's still high. So the smoking also one of the main risk factors there. Indonesia, even in Vietnam, look at the country like Vietnam and Philippines, you can see the alcohol. Alcohol also is another major factors there to contribute in a TB epidemics. So in terms of the impact, so we talk about the morbidity, we talk about the mortalities. So what's the impact actually in TB treatment outcome? When people smoke or continue to smoke even during the TB treatments, what would happen? So I think look at these are the many the pathway of the TB treatments. So there is an infection, there is and then the progression, and also the disease appear. There's treatments, all the process. What happens? So if you look at if people continue to smoke or exposed to passive smoking, what would happen? So you can see the TB infection because of the smoking is quite significant. And also that would also lead to develop the disease, that is TB. So that is also quite strong and quite significant. It's not only the active smoking, the exposure to passive smoking, the exposure to second-hand smoke is also a significant risk factor in progression of TB disease. So if people continue to the smoke during the TB treatment, like in Indonesia, do you know how many months we have? The patient has to take medicine, TB medicine. If somebody gets TB, what's the duration of TB treatment? How many months? At least 6 months, yes. At least 6 month TB treatment there. So if someone continue to smoke during the TB treatments, there is more chance to get relapse. So therefore, it's not only the problem or the factors to develop TB disease, but also it has a significant impact on the recurrence of TB. So of course, the mortality and delay in diagnosis. So people, if they are smoker, there is always that we have the data. The smoker who develop TB, they always go to the health facility to get the support, to get help. It's quite the longer compared to the non-smoker. I can show you the next slide. Oh, sorry. Here. This is some of the old study that we did in Nepal, just to compare the delay, to compare the health-seeking behavior among the TB patient. So we look at we divided in like a current smoker, ex-smoker, and never smoker. So if you look at the overall, it's quite high. It's more than more than 2 months, right? The patient, when they develop the symptoms, from that point until they get diagnosed and start TB treatments, it's more than 2 months. It's 2.5 months or something like this, right? 120, 103 days. Yeah, more than 2 months or close to 2 months, sorry. So here, so that is in general, overall. It's quite long. So usually what we say, the traditional definition of if somebody gets the TB, if you have a cough for 2 weeks or more than 2 weeks, we think like the person may have a TB disease and should be diagnosed within a month actually, but here it's significantly longer. But if you compare with the smoker and non-smoker, look at here, 133 days. People are living in a community, in a house, without any diagnosis, without any treatments. What does it mean? How can you translate in your public health language? That's a big thing. TB is a communicable disease, right? So if for example, if I have a TB, I stay in my home or in my community without any diagnosis, without any treatment until 2-3 months, what would happen? I can transmit the disease to my family member. I can transmit the disease to the friends. I can transmit the disease to the community. So, the whole community on risk, my family also on risk because of my no diagnosis, no treatments, or late diagnosis. Therefore, the smokers, they used to stay longer in a community without any diagnosis. Because what they think? We ask why. The primary symptoms of the TB, what is the primary symptoms of TB? Do you have any idea? The cough, right? Yes. So there are many. So it's a cough. So in Nepal, in a setting, they think the smoker TB patient, they thought their coughing is because of their smoking. It's not because of their anything, the wrong in their health. They thought, it's coughing because I smoke, so they don't go to health facility. They don't go to see doctors. They don't go to see any other healthcare provider. That's one of the reasons preventing the people to get the early health seeking from the puskesmas, from the hospital, from the health provider. Therefore, we need to do something about smoking in TB control program. So now we saw, right? We know the morbidity, we know mortality, we know the burden, dual burden of TB and tobacco smoking in whole process of TB treatments, and also in a whole process of the patient's life. So, what action do we need to take as a public health action? There are many approaches. One could be like more individual, that's more on treatments that we focus, individual care, and then at the same time we have to care about general population. So what are the key strategies that we need to take, what we need really? So the first thing, I think we need to have the leadership. What do I mean by leadership? I don't know, I just put their leadership. What is your opinion? Are we talking about the politician here, about leadership? Are we talking about the public health leadership, or are you talking about, I don't know what type of leadership you need. Any? Are you leader or not? You all are public health leader. You can make a difference. You can bring the solution, especially as a university. I think the university, the school of public health, or here now, you are solution. You are not a problem. Do you agree with me? All of you including me, we are a solution. We are not a problem. Where is the problem? Problem in a community. What is that problem? That's a disease, and we have to solve those problems. You are the key change maker in your community to solve the problem. If we don't solve the problem, if we don't bring any the new ideas or new strategy or new action, so we are not a leader. Therefore, we see you as our key future, the public health leader now. So therefore, leadership is one of the key aspects. It can be political leadership. You need political leadership. You need, the public health leadership. You need community leadership. You need religious leadership. You need the leadership from many aspects so that we can work together to address the issues. So within the leadership, there are three key components. One, leadership itself. I should be committed. And the second, I should be accountable. And I should find the ways to sustain the program. So as a leader, you need to think, you just not only start something, you have to think how to sustain that initiative that you are going to do. So therefore, we put like a leadership, accountability, and sustainability are the key management issues, management strategy to solve any of the public health measures, the problems. So we put here just in terms from the perspective of the government. Okay, when I say put like the things here, leadership, what are the key components? Legislation. You know, as I mentioned earlier, TB, if I have a TB, for example, if I am not diagnosed, not treated early, so what I do, I just transmit the disease to my family and the community member, right? So this is my right. Do you think that is my right to transmit the disease to others? No. And also, do you think it's your right, as a non-TB people, it's your right to get the disease, something from me? Of course not, right? So we have to respect the right, protect the right of the people, both with TB and without TB. How can we put together like that? We need to have some policies, regulation, law, so that mandates everyone the role and responsibility that can make everyone accountable, both with TB or without TB. Therefore, we need the regulation. At this point, there is no regulation. In a few countries, there is a TB legislation, but in many countries, there is no TB legislation. It's more on the voluntary. So people don't go, people can drop out in the middle of the TB treatments. So actually, it's not right. So we have to make really everyone responsible by creating a comprehensive the legislation and regulation. The second is the accountability, the health provider, the TB control program, or the Puskesmas or provincial health office or district health office, or we are part of building the awareness, building the capacity of the workforce and ourselves as well. I think that capacity, the implementation part, all those things needs to be also included under the accountabilities. The last, of course, we need money. We need resources. Both the financial resources and non-financial resources, the human resource, or other logistical the support. There are many that we need. So we need to ensure the leadership. For example, the Wali Kota, for example, Wali Kota of Denpasar, just an example. So whole Denpasar city is his responsibility to create a healthy city or healthy environment. So we need to really make the Wali Kota accountable to allocate enough resources for TB control or tobacco control program, for any health program. So that's, we need to have resources to make sustain program. Oh, sorry. Yeah. So these are some of the examples. I talk about political leadership. I'm sure you know this person, right? Do you know? Any of you know the? Anyone? He was the Wali Kota of Kota Bogar. Mayor Bhima, right, that time. So now he's a Wakil Mantri, Ministry of Home Affairs, Dalam Nagari. So he's very proactive, very action-oriented person who really leads the community in many public health issues, including tobacco control. So, he is one of the key champions. So what I mean here is we need the political leadership to ensure the capacity of the health team, to ensure the resources, and to really mobilize the whole community in tobacco control or TB control or HIV or any public health issue. You need to have the political leadership. So similar, I think we have something from other countries, from Bangladesh. I think these are from Bangladesh, yes. So we need those leadership at the community level, at the quota level. Also, we need the leadership at the political leadership at national level. And then we need to have a leaders to make the action, to translate the political commitment into action. That is you. That is all the public health community, as a student, as a teacher, as a public health worker. Whatever the roles that we play now, we all are leaders. We have to play that roles. And we need to translate political commitment into action. And we have to make them accountable. Okay. We talk about leadership and what type of action we can do as an individual or as an organization. So everybody can play the role as an organization, like as a Udayana University or as a faculty of medicine or a school of public health, we can play a big role. And also as an individual, you can play a big role. So when we say the TB and smoking, the first thing that we can do is a brief intervention. The integration of smoking cessation, support smoker to quit, that can be integrated in a regular public health program, for example, in a Puskesmas. So when the people visit there, in a Puskesmas, in a health center, they can simply provide some counseling. That is a public health approach, right? We do to provide the brief advice. Do we need the big machine or big resources? What do you think? No, it's just very simple. If anyone there, whether he or she smoke or not, just we need to ask. That's why we call ABC intervention. ABC. It's easy to remember. What is A? So if you are for example, in a Puskesmas, when I visit there for any health reason, you can simply ask me, do you smoke? You can diagnose the smoker, right? And if I say I smoke, then you can give a brief advice. Hello, Pa, this is smoking is not good for your health. That you can explain to the person and encourage him or her to quit smoking. And then the cessation support, if you have some resources, for example, if you have a poster, pamphlet, or you can show him, now everybody carries the mobile phone, you can provide him some online resources, whatever, if you have. That is cessation support, additional support. So A, B, C can be done by Puskesmas or university students or the teacher or the family member, everyone. I do like that in my family, in my community. So you can also do the same thing in your family, in your, the community. You don't need to be like a official, the government staff to implement ABC. It can be anyone. So you can ask your friend also, hello guys, do you smoke? If you smoke, please quit. At least you can say in 5 to 10 seconds. It helps a lot. In a public health, what is public health? We have to spread the message and communicate to the mass, to more people. The more people that we communicate, the impact that we bring also is larger. So therefore, please, A, B, C can be implemented by anyone. So it's a more, that's why we put in a TB control program, just ask each and every TB patient about the status of smoking, whether they smoke or not. If they don't smoke, then you can encourage them to remain non-smoker. So it's all the public health information and communication. So please remember A, B, C. So you can do in your family, in your workplaces, or in the school, or in your wherever you go, and whoever you meet. So these are some the data. You know what we achieve by implementing A, B, C for smoking cessation in TB control program. In India, we implement this in some of the health centers, some of the districts. What we achieve, you see, just asking, do you smoke? 89.6% of the male TB male patient, they said they do tobacco smoking. It's very easy. You don't need the X-ray machine. You don't need the the lab. You don't need anything to identify smokers. Very simple. Just you ask. If you means public health person, okay, the doctor, the paramedics, the nurse, if they ask about smoking status, the patient as a lay person, I think twice. Oh, maybe my doctor, my nurse, the public health expert asked me about smoking status. Maybe the smoking is not good for my health. They think in that perspective. So that's really good to ask the question to each and every visitor in the puskesmas. In Indonesia, that's it's implemented in Kota Bogor. Can you imagine? Almost all 96.7% of all male TB patients, they used to smoke. Huge number. The smoking is a big issue in a TB population in Indonesia. And you have seen the data that I have presented already from WHO as well. Big issues. 96.7% of the male TB patients, they used to smoke. I think still the smoking is a quite big problem among the TB patients. Similar in South Africa and also Nepal. So the brief advice, like as I mentioned, we ask the patient whether you smoke or not. And after that, once we identify the status of smoking, then the health provider provide a brief advice in each and every visit in puskesmas or health center or hospital. So like the TB treatments, almost 6 months, right? So during this 6 months, at least the patient used to visit, or still, I think they still visits about 5 to 8 times. 5 to 8 times they visit puskesmas or health center to collect medicine, to make a follow-up check, all. So those occasions, the puskesmas staff or the health provider, they can use as an opportunity. So as a public health, what we need to do, we need to tap the opportunity, right? The opportunities are there, but you need to really tap. You need to catch those opportunities and use that opportunity to maximize your public health efforts. So same thing, when the patient there in a health center to collect medicine, you can ask, do you still smoke? What is your smoking status now? Have you tried to quit smoking? If not, why? What are what type of support you need to quit smoking? I think if we do on a regular basis and implement in our primary health care, that would help a lot. So with these efforts, you can see in Bangladesh, 82% of the smokers quit smoking in 6 months. That means, why you can ask me in Bangladesh, do you know DOTS? DOTS? It's one of the approach for TB patient. Directly observed treatment short course. It means the patient has to take medicine in front of the supervisor. The supervisor can be family member or volunteer or health worker or anyone or or friend. So in a Bangladesh is a community health volunteer. The community health volunteer, they go to the patient home and provide the TB medicine every week. The visit is every week, weekly visit. So it means there are more occasions, right? More than 20 occasions, the health volunteer visit the patient. That's why at the same time they offer brief advice to quit smoking. Therefore, you can see 82% quit rates. The more interaction between the patient and the health provider, the results also quite high. So in India, 67%, but India only 4 times, maximum 5. So at the beginning of the TB treatment, when they start, and then the follow-up, 2 months, 3 months, 6 months, or 5 or 6 months, something like this, 4 or 5 times. So, but still, the smoking cessation, the quit rate is still quite high, 67%, through your brief advice. And also in Indonesia and China, also very similar. The Indonesian in Kota Bogor is every month, but they are 6 months, 6 times. The patient gets the counseling from the health provider, from the Puskesmas, and also similar in China. So the quit rate is still more than 65% in all those occasions. And you can ask the question, why Brazil in only 15%? In Brazil, what happened? In Brazil, there is only one session at the beginning of the TB treatment. One time, only the health center provide the counseling only one time at the beginning of the TB treatment, that is the first month. That's all. And after that, there is no any follow-up, month 1, 2, 3, 4, 5, 6. But still 15% quit rate among the smoker. It's nothing, it's better than nothing, right? At least 15% of the TB patients, they quit smoking, which is really good. So therefore, you can see whether it depends on the resources, it depends on the context, it depends on the workload of the Puskesmas staff. So, the smoking, counseling, the strategy can be different, country to country, even province to province, quota to quota, can be different. But the minimum, the bottom line is we need to have a smoking cessation integrated within the regular TB control program. Whether one-time counseling or 2 times or every month or every week or 3-4 times during the TB treatments. If we have that system integrated, then you can have better results in TB treatment outcomes and in TB elimination. We talk about TB, the quit rates, but this slide presents also about the exposure to second-hand smoke, passive smoking. As we mentioned earlier, as we discussed, passive smoking also equally danger to our health and also equally danger to the TB patient or for TB control programs. So what happens? So these are some questions that we monitor and we document the data at the beginning of the TB treatments and also at the end of TB treatment. Let me explain you. The current smoker, 0 month means at the beginning, when the TB patient start TB treatment. At that time, we ask them, do you expose to passive smoking or someone else smoking in your house, in your room? We ask the patient. The Puskesmas staff asks them. They said, yes, more than 83% of the TB patients, they said there is someone always who smoke inside the room, inside the home. And at the end of the TB treatment, that is 6 months, you can see again the similar question was asked to them: is there still anyone smoke inside the room, like inside this room? Only 14% they mention, yes, there is someone still smoke inside the room, inside the house. What does it mean? There is a significant reduction of the exposure to passive smoking. It means many of the smoker, even they continue to do smoking, but they make their room smoke-free. If there is someone smoking, they ask that person or parents or someone, sibling, to smoke outside, which is good. We really want to have a clean environment, like for example in this room, nobody is smoking here. So my request to all of you, you can do exactly the same thing. Start from our home. We need to start a small action somewhere. That is our house. If you guys if someone smoking in your house, the first thing you need to request and help that person to smoke outside. That is also public health practice, right? Public health practice. And at the same time, you have to also help him or her to quit smoking, which is really important. So public health action doesn't require you are a government official and you are posted at the health facility. No. Public health action can be done in any place. If you go in toilet, we go toilet, right? At least 3, 4, 5 times every day. If you see there is something wrong in a toilet, you can ask the maintenance, oh, there is something wrong that needs to be maintained. So that is also action, right? So we can do public health action in any time, anywhere. We don't need any responsibility. Our role is action. Let's do the action. So same thing in smoking. So even look at the ex-smoker, they are not smoker. They used to expose to second-hand smoke or passive smoking inside their house at the beginning of month, 67%, and at the end, it reduced to only 7%, which is very good. Here, this is very interesting. They are not a smoker. This group, they are not a smoker, never smoke. But they have a TB, but they never smoke. But when we ask, does anyone smoke inside your house? That means, do you expose to second-hand smoke? 76% they say yes. There is someone who smoke inside their house, and they are exposed to passive smoking. But during the 6 months, there is always A, B, C. They get the advice. Even someone smoking inside the room or inside your house, please help them to quit or ask them to smoke outside. So what happened at the end of the 6 months? You can see only 14% of they say yes, there is still someone smoking inside their house, but significant reduction. Reduced by huge number, huge percentage. That means even they are non-smoker, they help the parents or siblings or friends not to smoke inside the house, and also make their house clean and smoke-free. So it means it's not only the smoker. Anyone, non-smoker, can play a big role to create a healthy environment, help the friends and the parents, to quit smoking. Okay, sorry. Wait. Yes. Okay. In terms of impact, in TB treatment outcome, what is our optimal, the targets? So the person whom we put under the treatment must have a successful treatment at the end of 6 months, right? We want to cure her or him. I think that is something, the successful treatment we want. That is our optimum goal at the level at the individual level. And we want that levels, the 100% successful treatment outcome. So that means we want to really eliminate the TB disease from that person. So if you compare what happened at the end of 6 months, comparing among smoker and non-smoker. If you look at here, treatment success rate among the quitter is at 91%. Majority of the smoker who quit smoking, they have better TB treatment outcome. that is successful treatment outcome compared to non-quitter. There are some people who is still smoking during the TB treatments. Thus, the successful treatment outcome is it's low compared to the the quitter. But this is very important. It's a public health significance. If you look at here, relapse, recurrence, TB relapse, they cure and after a few months again get the disease back. That means if you look at among the quitter, the relapse rate is quite low compared to non-quitter. So if the people, they don't quit smoking during the TB treatments or after the TB treatments, there is a high chance to get the disease back or relapse. If they quit smoking successfully, and there is also less chance to get the TB disease back. So that means smoking is one of the main, smoking control or the cessation program should be one of the key pillars or the intervention within the TB control program. I think the last but not the least, this is my slide, what we need to do now. If we want to eliminate tuberculosis from our communities, what we need to do as a team, as a government, as a researcher, as a student, as a professor, or as the whole our community, what are the things that is needed? The first, as I mentioned, now it is required to have a TB legislation to put everyone accountable, to make everyone accountable, to build the accountability of each and everyone, whether they are TB patient or they are non-TB patient, whether they are smoker or non-smoker, doesn't matter. We need a strong regulation to build our accountability, to make me more accountable, for example, and to make us more accountable. That is very, very important. Because, as I mentioned earlier, it is equal right for a non-TB patient, right? People without TB, they don't have the right to get the TB disease from others. And vice versa, the TB patient, the people who have TB already, they have a right to get a full, comprehensive diagnosis, the treatments, treatment support, and also the other, the services that they require. So we need to work together. Both people with TB or without TB needs to work together, and both groups needs to be accountable. How can we do this? We cannot do without any rules, without legislation, without law, without regulation. Everybody says yes, yes, yes. But in reality, it doesn't work in that way. I think if we really want to eliminate tuberculosis, we need to have a national regulation, regional regulation, and even the regulation at the local level. So then that law, that regulation should mandate each and what is the role of the Puskesmas, what is the role and responsibility of Dinas Kesehatan and the national governments, and also the community and all individuals, whether they have TB or without TB. Then we can work together to bring the TB as a point of elimination. So that's why these are the two things that needs to be really addressed within the legislation. And when you say the legislation, it means there is a sanction, right? Fine. If you don't do this, there should be a both administrative fine and also financial fine or sanction. That is very important. I think we need to make everyone disciplined. The TB patient must complete the 6-month TB treatment. That is part, it's a discipline. And the other non-TB people must help them to complete. So it's a both. We all have to work together, but this should be mandated under the legislation. Second is a TB prevention program. We need a comprehensive TB control program, TB elimination program at national, sub-national level, even at the local level. So that includes some key strategy. I'm not going to talk details about the strategy, but the key strategy should be mass screening. It's not only the person based, we diagnose, we identify based on the symptom. Now we have a literature, right? So more than 50% of the TB patients, they do not appear or they do not have any type of symptom that we define, the TB symptoms. Without symptom, but they have still TB. So we need to screen all. For example, in this room, it's not only we screen the individual that has some symptoms like cough, or fever, or chest pain or something. We need to screen all, identify the TB, and treat all. I think that should be a key strategy for our TB elimination. TB vaccine, that is also something, now we have COVID vaccine, so everyone gets the COVID vaccine, and it has been, invented, actually, developed within 6 months. So, but there is no TB vaccine. It's a long process. We don't know when. But now the global community, they are committed to have this vaccine before 2030. Let's see. But that is another preventive measure for TB. So we need the TB vaccine. The most important part for TB vaccine and mass screening, early diagnosis, early treatment, what we need to have the investment from the government investment, private investment, and public investment all together. In terms of not only money, like I mentioned, how can we define the investment? Our time. So everybody, we are an ambassador. You are the key public health leader. Everyone can invest 1 minute if you see someone in your surroundings, whether in your house or in your community or in your school or in your workplaces. You think that person needs to go to the hospital or seek some healthcare services, please do that. We have to play the key role in our community. So, as I mentioned, of course, the cessation service should be included throughout the TB control program from national to up to community. The last but not the least other pillar is tobacco control. As I mentioned, if we don't prevent or eliminate tobacco, it is impossible to eliminate tuberculosis because we need to eliminate the risk factor, right? Tobacco, smoking, alcohol, and diabetes, HIV, the nutrition should be improved. So those are all the risk factors. And especially in the context in Indonesia, we need to have a very comprehensive tobacco control program because smoking is one of the major risk factors for tuberculosis in Indonesia. Therefore, the TB control program now needs to advocate for a comprehensive tobacco control program for both fiscal and non-fiscal. What do we mean by fiscal? Should be tobacco products in Indonesia is very, very cheap. Like you are all students, you can simply easily buy from your pocket money. So in one pack of cigarette here is very, very cheap, even less than $1 you can buy, right? But if a same pack in Australia, in Singapore is about $20. In Australia, it's more than $30. In Singapore, it's $20. It's quite expensive. I think the fiscal measures is really important and very, very significant in tobacco control, and also that would contribute, of course, TB elimination, to really discourage the smoker to continue, and also motivate the smoker to quit and prevent the youth and children to pick up. So non-fiscal measures is like there are many. The KTR, I'm sure you all know the smoke-free environment that we need to create, both in our house, in our workplaces, in our public places, in everywhere, wherever, that we have access, public access. All the environment should be smoke-free. And we let the people to smoke outside. It's not that means the smoking outside is good. Actually, it's not. Just to create an environment to help smoker to quit. So the first thing that we need to do, create a smoke-free environment in indoor and ban all types of iklan. tobacco advertising, promotion, sponsorship. I think one of the things, my request to all of you, if you look at it, I'm sure every day when you go back to your home and come in the school here, you are exposed to vape. Every 5 meters there is vape shop. And you can see also beautiful iklan, right? So that really trigger our children, our friends to pick up the vape. So what we need to do as a advocate here, as a public health advocate, as a public health, the leaders, you need to really push the local government to ban all types of iklan. I think that now you have an election, right? Already the leadership already there. The wali kota, the wakil wali kota, and the department head. I think there's something that as a student you need to push them to ban all types of iklan. That is also part of our public health approach. So there are some other intervention. I don't know whether you have seen any gambar on tobacco pack about the danger of smoking. So I think that is something. So one of the most cost-effective strategy to promote the public health awareness about the danger of smoking. If you have a larger, big gambar or picture on the pack, that would educate the people, at least smoker, about the danger of smoking and helps the smoker to quit, actually. So that is something we need to do. And of course, smoking cessation should be part of the comprehensive tobacco control program. Finally, this investment in tobacco control. We have a TB control program, and there is a resources, there is a human resource, financial resource. Of course, it's not quite big, not enough, but there is a system. But in many countries, there is a comprehensive tobacco control program from national up to local level. So what is needed now, that's why I talk about that legislation. We need to have a legislation to make sure that there is a tobacco control program from at the local level, at the province level, and also at the national level. So we are in Indonesia, so there is some progress, but we need to do more. I think that's the last slide, Pak Ketut. I have many questions also to ask our public leader here to learn. Then maybe I stop here. Yeah, thank you.
Okay, thank you, Pak Tara. Please have a seat. Yeah. Okay. I think it was a very comprehensive presentation, yeah. Updated also and a good sequence, presented in a good sequence, I think, yeah. Okay, we proceed to before the response from the three responder or commentator from the Zoom. I would like to maybe a little bit summarize what Pak Tara said in the presentation. Ini untuk memudahkan mungkin adik-adik ya, nanti bisa bertanya. Jadi tadi presentasinya sudah komprehensif ya dan sudah up to date. Kemudian juga sekuensinya juga bagus ya. Jadi mulai dari problem tadi disampaikan terkait dengan TB attributable smoking ya. Jadi TB yang disebabkan atau berkaitan dengan perilaku merokok. Jadi secara global ada hampir 1 juta ya atau 16% gitu ya. Kemudian tadi data terakhir juga 96%. Jadi di Bogor itu orang yang menderita TB itu merokok, hampir 96% ya, perokok ya. Kemudian risk faktor risiko dari TB juga tadi disampaikan selain gizi buruk, HIV, DM, alkohol, kemudian merokok itu ya. Secara global nomor 3 TB yang disebabkan oleh merokok, kemudian di Indonesia nomor 1 malahan ya. Jadi memang TB itu adalah penyakit yang sifatnya individual ya adik-adik ya. Jadi kalaupun di rumah adik-adik misalnya ada yang kena TB, tentu saja yang kontak erat dengan pasien TB di rumah itu risikonya besar ya. Tapi itu risikonya 50% dari penelitian disampaikan oleh Dr. Artawan. Jadi 50% proporsi orang yang punya kontak erat itu berisiko terkena TB. Sama dengan tenaga kesehatan yang kontak erat dengan pasien TB dulu ya, sebelum zaman COVID itu juga 50% kemungkinan kenanya. Ya, tapi sekarang setelah COVID itu sebagian besar kita lihat tenaga kesehatannya sudah pakai masker ya. Jadi saya rasa proporsinya menurun untuk terkena TB. Jadi maksud dari proporsi ini adalah adik-adik kalau di rumah tidak ada orang yang kena TB merasa bebas. Enggak ya, di sekitar kita itu masih risikonya besar. Ya. Kemudian burden ya, habis itu Pak Tara menyampaikan burden atau beban. Jadi memang Indonesia selain Cina, Bangladesh, India merupakan negara dengan beban TB yang tinggi. Ya, jadi hampir 31% kasus TB di Indonesia itu merupakan TB attributable smoking, jadi berkaitan dengan perilaku merokok. Ya, dan kematian atau case fatality rate-nya juga cukup tinggi ya, 17%. Ya. Kemudian dari sisi impact terhadap outcome, jadi sudah ada bukti kuat ya, jadi disampaikan oleh Pak Tara dari jurnal maupun publikasi ya. Jadi dari pasif smoking, jadi pasif smoker gitu ya, orang yang terpapar asap rokok orang lain gitu ya, itu 9,3 peluangnya untuk menderita TB ya, TB disease. Jadi relative risk atau risk ratio-nya 9,3. Begitu pula yang tadi di highlight juga 7,4 berpeluang delay diagnosis, jadi menunda untuk diagnosis, ya menunda pengobatan dan meningkatkan penularan tentunya. Ya. Kemudian strategi, masuk ke strategi, Pak Tara menyampaikan terkait dengan leadership, akuntabilitas, dan sustainability. Ini yang penting ya. Nanti adik-adik atau Bapak Ibu, kebetulan ada yang dari dinas, bisa lebih explore atau diskusi terkait dengan ini. Kemudian yang menarik juga tadi tentang action atau intervention yang dipaparkan oleh Pak Tara ya, terkait dengan smoking cessation clinic atau klinik berhenti merokok di puskesmas. Kalau di Kota Denpasar itu 11 puskesmasnya sudah punya UBM ya, unit berhenti merokok atau klinik berhenti merokok dengan menggunakan ABC intervention ya. Jadi yang sudah dilakukan prakteknya selama ini ya di setiap pelayanan TB itu di puskesmas ya, baik yang sedang mengikuti screening, sudah didiagnosis atau melanjutkan inisiasi treatment gitu ya. Jadi ataupun yang punya infeksi laten TB itu dilakukan ABC intervention kalau dia merokok. Jadi jadi ditanya, brief, jadi diberikan nasihat singkat dan dilanjutkan dengan berhenti merokok melalui layanan TB ya. Kemudian tadi juga disampaikan hasilnya cukup menarik ya untuk quit rate-nya. Jadi rata-rata atau persentase orang mau berhenti setelah dilakukan ABC tadi ya untuk berhenti merokok 66,8% ya, cukup tinggi. Kemudian juga mengurangi paparan asap rokok di rumahnya. Ya. Kemudian juga terkait dengan TB-nya sendiri, dengan tobacco control atau dengan klinik berhenti merokok itu atau program berhenti merokok itu sukses rate untuk pengobatan TB-nya meningkat. Ini cukup ini ya adik-adik ya, untuk sukses rate pengobatan TB itu karena tadi dibilang Pak Tara perlu 6 bulan, walaupun sudah dengan DOTS program ya, directly observed treatment. Jadi sudah ada PMO, pengawas menelan obat, tetap aja ada yang lost to follow up. Ya, jadi dengan bantu berhenti merokok itu sukses rate untuk pengobatan TB-nya meningkat, relapse-nya, recurrence atau kambuh kembalinya juga menurun, dan pemeriksaan sputum bakteriologis positif menjadi negatif itu lebih cepat. Ya, kalau merokok lebih lambat. Jadi kalau orang TB kan setelah dikasih obat itu nanti diperiksa lagi dahaknya, seberapa cepat dia menjadi bakteriologis positif menjadi negatif. Itu dipengaruhi oleh perilaku merokok juga. Ya. Nah, kemudian yang terakhir NTB. NTB ini program global ya. 2000 berapa NTB-nya? Siapa yang mau minta epidemiologi di sini? Epidemiologis NTB 2030 ya? Atau diundur sudah 2045 lagi ya? Karena kira-kira nggak tercapai 2030 ya. Ini serius ya adik-adik. Jadi TB ini regulasinya nasional ya, sudah menjadi program strategis sejak zaman pemerintahan Pak Presiden Jokowi. Kemudian di Presiden Prabowo juga mengiatkan quick win untuk eliminasi TB. Ya. Tapi nanti adik-adik bisa tanya, diskusi ya, bisa nggak tercapai NTB-nya 2030 gitu ya. Tadi juga disampaikan terkait dengan TB, prevention. Jadi tugasnya kita semua sebagai public health di sini ya, untuk meningkatkan program-program pencegahan TB dan juga tobacco control ya. Terkait dengan screening, bagaimana meningkatkan screening. Jadi sekarang Dr. Artawan sedang menggiatkan TB screening ya untuk mendeteksi kasus maupun terduga ya. Karena case detection kita sangat rendah. Suspect evaluation ini juga sangat rendah. Jadi artinya kasus TB yang ada sekarang itu estimasinya jauh lebih rendah dari estimasi yang sebenarnya. Bahkan kurang lagi dari 50% ya. Mungkin nanti bisa ditambahkan juga oleh dari Kemenkes ya. Kemudian juga pentingnya tadi tobacco control regulation dan juga tobacco control program ya. Jadi ini peran serta kita semua di public health, nanti bisa diskusi lebih panjang di situ. Ya. Okay, I think that's your summary, sir. I try because it's very hard to find. Before we proceed to the discussion, I would like to invite our responder. Maybe you can join here, sir. Selamat pagi, Ibu Hanifah ya. I would like to introduce first our responder or commentator. The first is the Health Administration Associate Expert, member of Tobacco Related Disease Control Working Team, Ministry of Health. Jadi dari anggota tim kerja Tobacco Control di PTM ya, penyakit tidak menular, Ibu Hanifah Rogayah, SKM MPH. Kemudian yang kedua, Expert Epidemiologist Tuberculosis Working Team, jadi tim kerja untuk TB di Ministry of Health atau Kemenkes, Dr. Rina Handayani MKes. Kemudian yang ketiga ada Asia Pacific Cities for Alliance S.Ked Media and Citizen News Service CNS editor Mr. Bobby Ramakan. Tapi Bobby Ramakan tidak bisa join ya? Oh sudah habis. Oke. Mungkin kesempatan pertama, please Ibu Hanifah Rogayah, ada tanggapan atau pembahasan terkait dengan topik yang disampaikan Pak Tara tadi terkait TB dan tobacco control. Silakan Ibu.
Ya, terima kasih. Mohon maaf, saya tidak bisa membuka kamera karena sedang di kegiatan yang lain. Ya, terkait tadi saya izin menyampaikan dengan bahasa untuk tanggapannya. Suara saya terdengar?
Oke. Mungkin bisa lebih keras Ibu.
Ya, suara saya terdengar sekarang?
Terdengar tapi agak sini. Yang lain gimana? Oke, silakan.
Ya, terima kasih. Kami dari Direktorat Pengendalian Penyakit Tidak Menular, jadi dari tim kerja pengendalian penyakit akibat tembakau dan penyakit paru. Izin karena Ibu Direktur berhalangan hadir, mohon maaf, jadi disampaikan kepada kami. Betul sekali bahwa tadi yang sudah disampaikan Dr. Tara, bahwa yang menjadi perhatian sekarang adalah tadi sudah bahwa TB itu salah satu faktor risiko yang pertama malah untuk Indonesia adalah pengendalian penyakit merokok, perilaku merokok. Jadi untuk merokok ini di Indonesia pada tahun 2021 berdasarkan hasil GATS itu meningkat terus di mana ada 70,2 juta orang, dan yang memperhatikan kembali juga adalah peningkatan untuk rokok elektronik yaitu 10 kali lipat. Kemudian untuk paparannya juga bahwa hampir 68,6% itu memang terpaparnya di ruang tertutup. Jadi mana misalnya untuk yang menjadi perhatian negara saat ini adalah penurunan prevalensi merokok untuk usia 10 sampai 21 tahun. Nah, dari paparan ini 6 dari 10 anak di Indonesia itu terpaparnya di rumah, kemudian 7 dari 10 anak itu terpaparnya di tempat umum, dan hanya 1 dari 2 anak memang yang masih terpapar juga di sekolah. Kemudian bahwa untuk tren untuk perilaku merokok di Indonesia memang secara angka berdasarkan SKI itu menurun, yaitu dari 9,1 menjadi 7,4%. Namun yang memperhatikan adalah ini sebenarnya belum mencapai target karena seharusnya penurunannya itu adalah 30% atau dari tahun 2019-18 itu harusnya adalah 6, jadi sebenarnya prevalensi merokok Indonesia tidak bisa diklaim untuk menurun secara keseluruhan. Kemudian tadi memang rokok elektronik itu meningkat 10 kali lipatnya, yaitu dari 0,3 menjadi 3%. Dan ini tentu saat ini trennya memang banyak yang mengakses untuk rokok elektronik adalah pada usia 10 sampai 18 tahun. Dan memang secara PTM juga untuk rokok ini menjadi penyebab atau faktor risiko terbesar setelah hipertensi adalah merokok, kemudian bebannya juga yang tertinggi setelah tekanan darah adalah merokok. Nah, gambaran untuk penyakit rokok Indonesia sendiri tadi juga sudah disampaikan berbagai penyakit yang bisa diakibatkan oleh rokok, yang juga memperberat untuk pengendalian PTM selanjutnya. Jadi memang betul bahwa relatif atau keterkaitan untuk TB tadi tidak hanya dari faktor perokoknya sendiri, tapi juga rokok pasif. Nah, ini juga bahwa untuk pengendalian tembakau di Indonesia itu dengan pendekatan empower, di mana yang terkait yang bisa kita dorong itu tadi sudah disinggung juga oleh Mr. Tara, yang secara non fiskal ya, yaitu untuk konsumsi, penurunan konsumsi, kemudian perlindungan paparan asap rokok juga dengan upaya berhenti merokok. Kemudian kita juga menurunkan eliminasi iklan produk dan sponsorship produk tembakau. Nah, jadi juga yang sekarang tentu diperhatikan tadi untuk definisi perokoknya itu tidak hanya rokok konvensional, tapi juga rokok elektronik. Dan sebenarnya tadi yang disinggung oleh Mr. Tara tentang terkait leadership, nah itu di Indonesia sebenarnya untuk pemerintah Indonesia saat ini konsistensinya untuk lebih melindungi terhadap prevalensi merokok itu adalah dengan adanya dikeluarkannya peraturan pemerintah nomor 28 tahun 2024 sebagai turunan dari Undang-Undang Kesehatan, di mana pada salah satunya untuk beberapa pasal, yaitu ada sekitar 10 yang terkait yang melindungi untuk pengamanan zat adiktif dan tembakau. Yang pertama adalah bahwa untuk jumlah batang kemasan itu sudah dilakukan pengaturan. Kemudian larangan penjualan juga, bahwa anak di bawah 21 tahun tidak boleh mengakses rokok, kemudian tidak penjualan dengan rokok batangan atau eceran, kemudian tadi juga disinggung banyaknya iklan di sekolah. Nah, memang itu sudah nanti di PP 28 itu diatur bahwa di radius 200 meter itu tidak boleh ada penjualan rokok. Juga pada radius 500 meter itu tidak boleh ada iklan rokok. Kemudian untuk standar kemasan atau PHW itu juga sudah dilakukan, di mana tadinya 40% itu menjadi 50%. Kemudian juga untuk ketentuan kawasan tanpa rokok, di mana tadi untuk melindungi paparan asap rokok atau mengurangi aktivitas merokok yang ada di 7 tatanan aturannya. Kemudian juga pada pasal PP 28 ini juga mengatur tentang pengawasan terhadap iklan. Jadi kita juga berusaha untuk menurunkan paparan iklan ini sehingga tidak menambah jangkauan konsumen khususnya untuk usia 10 sampai 21 tahun. Kemudian sebenarnya terkait KTR ini yang tadi diamanatkan oleh PP, dan mungkin kalau di Indonesia itu ada sekitar 374 daerah yang sudah punya peraturan terkait kawasan tanpa rokok. Jadi ini diharapkan karena dia menentukan untuk KTR itu di 7 tatanan, sehingga kita berupaya semakin banyaknya daerah yang mengimplementasikan kawasan tanpa rokok, maka untuk menurunkan paparan asap rokok dan juga mengurangi untuk aktivitas merokok di 7 tatanan ini. Kemudian tadi terkait layanan upaya berhenti merokok atau smoking cessation, memang di Indonesia hampir 4.600 puskesmasnya. Tadi juga disampaikan bahwa di seluruh untuk Provinsi Bali ya memang sudah punya upaya berhenti merokok. Dan ini memang kita sudah berintegrasi dengan untuk program TB, di mana nanti memang baik itu secara pencatatan ataupun program nanti juga ada dilakukan tagging bahwa ketika dia menderita TB ditanya apakah perilaku merokok. Begitu juga dengan adanya upaya cek kesehatan gratis di mana pada usia di atas 18 tahun itu ditanyakan riwayat untuk merokok, apakah dia merokok atau tidak. Jadi di setiap orang yang melakukan cek kesehatan gratis itu dilakukan tagging untuk riwayat perilaku merokok. Ini berupaya kita bagaimana bahwa masyarakat juga tahu bahwa status merokoknya juga dipantau, sehingga juga kalau nanti keterkaitan dengan TB ataupun penyakit lainnya, begitu dia merokok juga akan dilakukan intervensi terhadap integrasinya juga. Kemudian memang kalau untuk saat ini kita harapkan adalah UBM itu tidak hanya juga sebenarnya dengan TB, tapi juga beberapa program lain. Dan memang saat ini untuk TB, tadi sudah pada masuk pencatatan pelaporan di SITB ya, untuk TB-nya. Kemudian dan memang kita harapkan nanti tadi yang disampaikan Mr. Tara, kalau di Indonesia itu dengan 4T untuk upaya berhenti merokoknya, yaitu tanyakan, telaah, tolong, dan nasihati, serta tindak lanjut. Nah juga yang tadi kalau misalnya memang betul kalau di setiap klien TB ataupun pasien TB yang mengakses ke puskesmas, maka memang kita harapkan yang pertama adalah meminta pasien TB yang merokok atau paparan rokok untuk kelainan UBM, kemudian memberikan nasihat singkat tentang berhenti merokok, serta memberikan dukungan untuk berhenti merokok dengan pemantauan yang teratur. Jadi di program upaya berhenti merokok pun juga ada dilakukan follow up ataupun tindak lanjut begitu seorang klien untuk berhenti merokok, maka dia akan dilakukan follow up selama 7 kali dalam 1 tahun. Dan ini juga secara pendanaannya juga didukung oleh pemerintah melalui BOK non fisik di puskesmas. Jadi tadi kami sangat sepakat dan Indonesia memang sudah sangat memperhatikan ini bahwa tidak bisa kita kalau pengendalian merokok berjalan sendiri-sendiri, tapi harus terintegrasi dengan layanan TB juga. Saya kira itu tanggapan kami. Terima kasih.
Baik, terima kasih Ibu Hanifah atas tanggapannya. Mungkin nanti juga Pak Tara akan merespon. Kemudian kita lanjutkan dulu untuk penanggap berikutnya. Jadi Ibu Dr. Rina, apakah sudah join? Jadi informasi Ibu Dr. Rina akan share screen ya Ibu ya?
Iya, apakah bisa
Memungkinkan bagaimana?
iya bisa ya.
Bisa Bu, bisa silakan.
Ya,
Mohon teman-teman bisa bantu untuk
saya berusaha share screen ya.
bisa jadi host.
Bentar. Apakah sudah tampak?
Sudah Bu?
Sudah ya?
Ya, sudah.
Ya. Terima kasih Pak
Kurang
Ketut.
lebih 10 menit ya Ibu.
Ya. Saya memang perlu sedikit ya share screen supaya lebih mudah menjelaskan. Jadi seperti tadi disampaikan oleh Dr. Tara ya, memang di Indonesia itu menjadi sangat konsen ya, karena nomor 2 di dunia setelah India, dengan perkiraan kasus per tahunnya 1.090.000 dengan kematian 125.000 per tahun. Sama seperti yang disampaikan Dr. Tara tadi. Nah, kondisi ini ya membuat kita konsen sekali untuk melakukan penemuan, pengobatan, pencegahan ya, sehingga nanti kita bisa NTB gitu ya. Nah, ini notifikasi kasus di tahun 2024 itu kita sudah ketemu sekitar 884.000 kasus. Nah, dari target yang 90% dari 1.060.000 itu 900.000. Dengan kasus kematian yang diobati ada 90%, yang SO pada harusnya 100.000. Jadi kita memang sudah berusaha maksimal ya ini, tapi memang masih ada kekurangan. Nah, ini kita akan melakukan lagi inovasi-inovasi agar penemuan kasusnya, pengobatannya, ya, penata laksanaannya, pencegahannya ini bisa sesuai dengan target. Ya. Nah, peta jalan eliminasi TBC di Indonesia sesuai dengan target global tadi ya. Nah, diharapkan di target global ya, menyesuaikan target global saat ini mulai tahun 2025 target nasional itu diharapkan insidennya itu pada tahun ini itu bisa turun menjadi 163 per 100.000 penduduk, yang ketika 5 tahun kemudian di tahun 2030 insiden bisa turun 80% atau 65 per 100.000 penduduk dan kematian turun menjadi 6 per 100.000. Nah, indikator yang yang dibuat adalah pertama treatment coverage itu harus 90%, success rate-nya harus 90%, TPT-nya untuk kontak serumah harus 70%. Agar nanti di tahun 2030 nanti insidennya bisa turun 80%, gitu ya. Nah, itu semua ketiga indikator ini harus bisa kita penuhi. Nah, salah satu upaya yang dilakukan adalah memang pertama sejak tahun 2021 itu sudah ada Perpres. Nah, memang seperti disampaikan tadi oleh Dr. Tara, kita tidak hanya bisa bekerja sendiri. Nah, itu harus melibatkan lintas program maupun lintas sektor, ya. Lintas program mungkin tadi seperti UBM ya yang sudah disampaikan presenter sebelumnya, penanggap sebelumnya. Nah, untuk untuk membuat payung pelaksanaan lintas sektor ini ada dibuat peraturan presiden nomor 67 tahun 2021. Nah, nanti di dalamnya ini ada pengaturan tentang penanggulangan TBC dari target dan strategi nasional eliminasinya, pelaksanaan strategi nasionalnya, kemudian tanggung jawab pemerintah pusat dan daerah seperti apa, koordinasi percepatan penanggulangan TBC, peran serta masyarakat, dan pemantauan evaluasi dan laporan maupun pendanaan. Jadi teman-teman sekalian, saat ini program TBC itu sudah didukung banyak sekali kementerian yang lain, gitu ya, seperti Kementerian Desa, Kementerian Tenaga Kerja, Kementerian sosial seperti itu ya. Jadi banyak lagi, cuman saya mungkin nggak cukup menyampaikan satu persatu sekarang ya. Nah, sekarang ini adalah yang berhubungan dengan perilaku merokok. Sama seperti yang disampaikan Dr. Tara, bahwa Indonesia itu merokok itu merupakan risiko terbesar pada pasien TBC. Itu berbeda dengan global. Kalau global itu nomor satunya undernourism. Merokok itu nomor 4, tapi memang seperti disampaikan Dr. Tara tadi, ini benar-benar harus kita konsentrasi betul situasinya karena kejadian pasien TBC dengan merokok itu ada lebih dari 100.000 ya, sekitar 150 ribuan. Jadi ini perlu mendapatkan penanganan yang lebih khusus ya. Di antara 5 ini, nah kami dari program itu sudah membuat petunjuk teknis gitu ya terkait komorbid, namanya adalah petunjuk teknis TBC komorbid. Nah, di dalamnya ada 5 konsentrasi ini yang merokok, malnutrisi. Kalau yang merokok ini kita sudah bekerja sama dengan UPM ya, kemudian undernutrition, SIV ini sudah lama, kemudian diabetes dan alcohol use disorder. Nah, ini memang yang keempat ini belum terlalu, tapi nomor 5 belum, tapi yang 1 sampai 4 itu kita sudah melakukan screening. Jadi semua sekarang ini kita melakukan active case finding. Active case finding itu sudah tahap 3 untuk tahun 2025 ini. Active case finding ini kita menemukan kasus secara aktif ya pada yang pertama kontak serumah. Jadi kontak serumah itu kita undang ya, kita active case finding itu mengundang kelompok risiko ini untuk dilakukan screening ya. Yang pertama kontak serumah kita undang, kemudian merokok, undernutrition, SIV, dan DM. Nah, kelima kelima kasus ini itu kita lakukan screening TB dengan menggunakan X-ray. Jadi menggunakan X-ray. Cuman kalau yang merokok ini baru screening aktifnya baru mulai tahun 2025. Ya, jadi mungkin saya belum bisa menyampaikan angkanya, tapi ini kita sudah mulai kerjakan. Ya, kalau tahap sebelumnya, ya, ACF sebelumnya itu masih berupa screening kontak serumah. Walaupun screening diabetes juga kita screening diabetes kita lakukan tersendiri. Tapi kalau sekarang dengan ACF tahap 3 itu semuanya dibarengkan. Jadi ketika kita melakukan screening di suatu kabupaten ya di puskesmas, kita harus mengundang kelima ini ya, untuk dilakukan screening selain kontak serumah. Nah, untuk screening dan diagnosis TBC pada perokok sendiri, seperti disampaikan oleh teman presentasi sebelumnya, bahwa pada pasien TB yang kita ketemukan itu harus dicatat dan dilaporkan. Jadi kita sekarang nggak bisa TBC diobati udah, ya teman-teman dokter ya menemukan walaupun di tempat praktek, walaupun praktek mandiri di klinik swasta itu harus melakukan pencatatan dan laporan, termasuk di rumah sakit. Kalau nggak bisa diklaim BPJS, misalnya di rumah sakit ya. Nah ini untuk yang pasien TB ya, TB ketika dia akan dicatat dilapor ke dalam SITB, ada pertanyaan-pertanyaan, salah satunya terkait dengan status. Tadi misalnya HIV, iya ya, sudah ya, diabetes juga. Nah, perokok juga masuk. Nah, di perokok itu akan ditanyakan apakah mereka merokok atau tidak, gitu ya. Saya lanjutkan ya, seperti ini pertanyaannya, alurnya. Nah, seperti ini. Jadi, ketika pasien TBC, terduga TBC masuk ke dalam poliklinik, itu akan ditanyakan apakah merokok atau tidak. Kalau iya, berarti layanan tersebut, ya dokter yang memeriksa itu harus memberikan satu nasihat singkat, ya. Kedua, arahkan untuk berhenti merokok. Apabila kesulitan berhenti, rujuk ke layanan UPM. Apabila tidak, ya tidak sulit hanya dengan edukasi oleh layanan yang memeriksa pasien TBC bisa dilanjutkan untuk beri rokok dan langsung diberikan OAT. Kemudian apabila dia tidak ada status merokok, ditanyakan juga apakah terpapar asap rokok oleh orang lain atau tidak. Kalau iya berarti harus diedukasi juga ya, harus diminta mengedukasi yang merokok dan dia disarankan untuk menjauhi rokok pasif ya. Kalau iya berarti berikan selamat dan motivasi untuk tetap tidak merokok. Jadi ini strategi yang kita lakukan terkait TBC dengan merokok. Itu yang pertama adalah memberikan poster edukasi berhenti merokok. Kemudian nah ini utilisasi klinik UPM berhenti merokok. Nah ini memang seperti tadi disampaikan dari presentan sebelumnya ya, kalau di seluruh Indonesia itu klinik UPM sudah ada gitu ya. Nah hampir cukup lengkap. Nah ini memang yang penting kita memang sama-sama melakukan sosialisasi ya, bahwa klinik UBM itu ada. Karena kalau teman-teman ke layanan itu jarang UBM itu ada pasiennya gitu ya. Nah dengan kita mengirim dari poliklinik ke UBM ini diharapkan ini bisa juga aktif gitu ya. Kemudian terapi farmakologi, implementasi kawasan tanpa rokok, dan advokasi pengurangan iklan. Demikian tanggapan dari saya. Terima kasih.
Baik, terima kasih Ibu Dr. Rina ya dari tim kerja Tuberculosis Kementerian Kesehatan. Jadi cukup jelas ya adik-adik dan Bapak Ibu sekalian, tambahan dari kedua penanggap terkait dengan tuberculosis control dan juga TB-nya. Maybe your response wait until the third one. Mungkin yang ketiga dari Mr. Bobby ya. He's already joined. Mr. Bobby, hello.
Hello, yes, good morning. Yes.
The time is yours. 10 minutes.
Yes. Yeah. Thank you so much to everyone. And thank you, Dr. Suarjana, Dr. Ibuputu Ayu, and of course, Dr. Tara Singh Bam. It was such an important talk today and very enlightening, especially with the World TB Day coming up so soon. So I think I would like to the best part of this session is that very important things have already been said. I think Dr. Tara Singh Bam has made a very strong case again, reminding people why it is so important to address the two epidemics of tobacco and TB. And Dr. Tara Singh Bam's comment was very important that it is about rights and responsibilities. So rights comes with responsibility. So of course, but it is also about the governments that they need to make sure that people are not at risk of tuberculosis. Those who are at risk of TB are getting the services they need with right in people-centered manner, and those who are not infected with TB, they need to be protected, and that is extremely important. But I have something to say here. Lot of investment has gone into the research for TB. Now we have very important diagnostic tools which can screen people for TB early and accurately. We have a lot of evidence, scientific evidence for collaborative activities between TB and HIV, TB and diabetes, TB and tobacco. So a lot of, for example, there are tests which can tell a person is at risk of diabetes, or whether the person has a risk of HIV, or of TB. You can test them. But what about tobacco control? In tobacco use, you do not need a test. We never needed a screening test or a confirmatory diagnostic test for tobacco use. What is the excuse then? Why have we not acted on tobacco control? Why have we not stopped or encouraged people to quit tobacco use? Why have we not held tobacco industry to account? Because in TB there is a bacteria, but in tobacco, which is all governments are trying to prevent people from this bacteria and other viruses and parasites and other fungi and other disease causing pathogens. But in tobacco, epidemic is totally propelled by an industry, and we have laws in every country to protect the rights and well-being and health of people of that country. So we need to ensure, we need to really hold ourselves to account, but also tobacco, our own leaders and our own communities to account, that we really need to push for integrated health and development programs. So Dr. Tara Singh Bam presentation was so bang on spot. For example, on cessation, with the point which he made, look at the synergy between not only the bacteria and the tobacco industry propelled tobacco product. So they also join hands. So people who are using the tobacco product are at a very high risk of TB. They are also at a high risk of bad TB treatment outcome and death, of course. And we also saw this synergy between COVID and TB, or COVID and tobacco use and NCDs. So but when it comes to programmatic implementation, I think we really need to do a lot more than what is being currently done. And there is no excuse, because this is also very important. It is high time we improve program outcomes at the local level, because that is where the global goals or country goals are going to be translated into reality. If Indonesia has to end TB or end tobacco, prevent NCDs, end zero hunger, zero poverty, it has to be the real work has to be done at the ground level. And I think that is where we need to make sure we break the silos, we break the walls between different programs. We ensure that programs are working together more effectively, collaborating more effectively, and so that people are protected from tobacco epidemic, as well as they are not at risk of TB, and those who need the services, they are getting those services. So the theme of this World TB Day is really important. Like, we of course need to invest and deliver, but we can't only deliver for TB. So I am currently in Delhi, and there are the 90% of TB is among homeless people and migrant people. So, but do they only have TB? The homeless people also have a very high level of malnutrition, undernutrition. They also have very high other kinds of abuses. Homelessness in itself is a very big problem in any society. So, or for example, migrant people, they also need decent living, decent so that the way they live their life and earn their livelihood is with the dignity of a human being, and it is not putting them at risk of different diseases. And of course, like they are protected, they know, they are aware of their rights, and also, as Dr. Tara Singh rightly pointed out, of their responsibility to ensure that they are completing the treatment, taking services which are being offered to them in people-centered manner, and protecting not only their own communities but also others. So I think it is very high time for integrated responses, so that different programs are really unitedly delivering things to the people who need them, especially in our countries. And I will quickly like to make another very important point is about the media. I think it is the kind of front page news, the main headline news, the breaking news. I think we really need to double check. Is it like, where are their priorities, and what kind of messages are being served to us? It is high time that the news which really matter to you, to me, to our people, to our families, to our communities is the headline. So it is not just about World TB Day. Every day in Bali, every day in Indonesia, every day in India, every day in Delhi, every day in the community we are living in, people are dealing with preventable illnesses, preventable diseases, infections that could have been prevented. And tobacco use in itself is a problem, because it puts people at risk of, very high risk of, not only TB, but also so many other life-threatening diseases which could have been prevented. First of all, it could have been prevented, and that is extremely important, because every opportunity of when we miss a case of TB, it's a failure. It's a failure to prevent. We have the tools, we have the science which that we could have found that person early. One of our close friends and guide, Dr. Sood, says, is a DTO, district TB officer in he said that every TB death is a reminder that they could have done better. I think that is a very humbling statement, because it is a very important and serious issue, that we could have diagnosed TB early, maybe we could have treated the person with the right medicines, maybe we could have done tobacco control better, so that the person would have quit tobacco use earlier and reduce the risk of TB. Or for example, nutrition. Maybe we could have done better on the nutrition, so that there are so many things we could think about on how could we have done better, so that no one needs to suffer from any infection which is preventable, any disease which is preventable, or any, and of course, what Dr. Tara Singh's bomb, one of the last slides is very, very important about leadership. We don't only have to look leadership, of course, others. First of all, we have to look inwards and stand up and rise for our own health, well-being, rights. But of course, we need to hold others also to account, ourselves to account, but also others to account, so that they take the responsibility, do their duties, and make sure that we are delivering on the global goals at the local level. I think that is extremely very important. I know we are perhaps running a little bit behind schedule time wise, but will be very happy to take any questions if there are any. Thank you so much again, Dr. Suarjana.
Thank you very much, Bobby Ramakan from S.Ked Media, for your sharing. Please stay. Hopefully you can stay in Zoom. So we need to hear from you, maybe a question from the participant. Terima kasih para responder, ada tadi Pak Bobby Ramakan, kemudian Ibu Hanifa, dan juga Ibu Dr. Rina ya dari kementerian terkait dengan tambahan dari masing-masing keahlian beliau. Ya, mungkin next Tara, you need to respond first from the responders. Or add something, or we wait for the discussion ya. Baik, terima kasih sekali lagi untuk responder ya. Kemudian kita masuk ke sesi diskusi untuk partisipan baik yang ada di luring ya, di ruangan ini maupun yang ada di Zoom. Sebagai informasi dari panitia juga menyediakan merchandise yang menarik bagi penanya ya. Ini untuk membangkitkan semangat adik-adik untuk bertanya ya, terutama yang public health ini, dan juga Bapak Ibu yang dari undangan juga bisa. Dari profesi dokter juga ada, public health, dari Undira, dari mana lagi? Banyak ya. Silakan adik-adik, Bapak Ibu. Kita juga sudah ada beberapa pertanyaan di Zoom, nanti mungkin saya rangkum aja sekalian. Kalau ada yang di sini mungkin 3 penanya dulu, silakan. Ayo. Hadiahnya menarik. Ya, silakan. Ada mic atau harus berdiri di mana ya? Ada mic ya? Tunggu sebentar deh ya. Nanti yang bertanya boleh bahasa Inggris atau bahasa Indonesia. Silakan. Nama dan dari mana? Ya.
Baik, perkenalkan nama saya Yusayu Putumutiari Dewi. Saya PSSKM Angkatan 24 dari Universitas Udayana. Jadi saya izin bertanya menggunakan bahasa Indonesia. Nah, sebelum itu beberapa negara ini telah berhasil menurunkan angka kejadian tuberkulosis dengan mengadopsi kebijakan pengendalian tembakau yang ketat seperti peningkatan pajak rokok, terus larangan iklan tembakau, dan penyediaan program berhenti merokok yang luas. Contohnya itu ada negara Thailand. Nah, negara Thailand ini itu udah menerapkan kebijakan pengendalian tembakau seperti melarang iklan tembakau di media cetak, radio, dan televisi. Nah, mengingat bahwa kebiasaan merokok di Indonesia ini masih cukup tinggi dan juga merokok dapat meningkatkan risiko terkena tuberkulosis. Nah, menurut Dr. Tara, apakah kebijakan semacam ini itu dapat diterapkan secara efektif di Indonesia tanpa memberikan dampak negatif bagi masyarakat, khususnya di ekonomi? Nah, mengingat Kementerian Perindustrian atau Kemenperin ini pernah menyebutkan bahwa industri rokok itu berkontribusi besar dalam pendapatan negara. Sekian pertanyaan dari saya, terima kasih.
Baik, terima kasih Tari Dewi ya, sangat bagus pertanyaannya. Ada yang lain mungkin, I think you understand fully ya, don't you? Ya, mungkin 2 penanya lagi sebelum Pak Tara memberikan respon. Silakan, tadi sudah pertanyaan yang baik ya. Silakan, ada yang lain, yang seniornya semester 6. Ya, oh ada ya, silakan.
Tunjuk sama pembimbing.
Pembimbing apa nih? Profesi ya, KKM-nya ya, silakan.
selama
Dio ya?
Iya dok.
Ya, dulu saya juga yang pembimbing di PE-nya ya.
Iya, dok.
Silakan Dio.
Saya izin bertanya, mungkin dengan bahasa Indonesia juga ya Pak. Saya izin bertanya mengenai bagaimana dampak atau bagaimana keberanian kita sebagai dokter atau klinisi untuk secara terus-terusan menekankan bahwa berhenti merokok atau sesasi merokok itu penting, karena dari yang saya alami selama 1 tahun di belakang ini jadi first year in medical student in my clinical rotation, bahwa rakyat Indonesia itu ternyata benci sekali di lecture, benci sekali dikritik. Jadi bahkan dari pengalaman saya di Posyandu selama beberapa hari di belakangan ini, banyak masyarakat yang bahkan berhenti datang ke Posyandu karena di lecture tensinya tinggi. Itu gimana? Nah, jadi apa dari tadi yang disarankan bahwa dari setiap pertemuan dan setiap follow up sebaiknya kita menekankan kembali bahaya merokok. Tapi apakah dengan menekankan seperti itu tidak membahayakan loss to follow up pada pasien? Jadi concernnya itu yang pertama. Dan untuk pertanyaan kedua, saya ingin menanyakan pertimbangan mengenai alternatif rokok dengan resikonya terhadap tuberkulosis. Jadi apakah metode-metode alternatif rokok juga tidak mendiminish keuntungan dari perhentian merokok? Misalnya apakah tobacco yang chewable, tobacco yang edibles, atau bahkan nicotine patch itu tidak memiliki dampak negatif terhadap treatment tuberkulosis. Jadi apakah ada perbedaan signifikan antara langsung berhenti merokok, full berhenti merokok dengan bantuan berhenti merokok lainnya? Jadi mungkin concern itu adalah concern saya. Terima kasih dokter dan terima kasih Pak.
Ya, terima kasih Dio ya. Ini pertanyaan cukup menantang ya, sangat baik. Silakan atau kita respon dulu ya Mbak ya. Karena ada satu dari chat juga dari Zoom. Ini kebetulan sih untuk Kemenkes ya, nanti mungkin untuk Ibu Dr. Rina ya dari tim kerja TB ya. Mungkin yang di luring dulu terkait dengan pertanyaan dari mahasiswa Utari Dewi ya, dari Mutiari Dewi dari PSSKM. Do you fully understand the question? It's about the tobacco control policy in the other country compared to Indonesia. They can implement it well compared to Indonesia, because in Indonesia the policy also have a negative impact in the economic, something like that. Our Ministry of Industry said that. And then what is your opinion about that? And the second one is from Dio regarding the resistance from the people, particularly the smokers. If we have our education them and then a brief advice, suddenly they just not come again to the service. And then about the nicotine replacement therapy, is there, or the other cessation therapy, is there any effect for the TB treatment? Ya, mungkin gitu ya kira-kira Dio ya. Maybe you can respond.
Thank you. I think it's a really great question. Some of the question maybe I can contribute to answer. I think we have the Ibu Hanifa from Ministry of Health and Ibu Rina, right? Yeah, from TV also, they can also help to answer this question. And of course, the Pak Ketut and Ibu Ayu, you can also help me to. So one thing is regarding the tobacco control policy in other countries. In all other countries, the tobacco control policy is really good. Why I'm saying the good, like for example, in Thailand or India or Singapore or even Malaysia or any other country in ASEAN or global, total ban of tobacco advertising, promotion and sponsorship in all other countries. So that means in those countries, this is one of the key strategy, marketing, right? Marketing is the key strategy for tobacco industry to influence the young children to pick up smoking. So in other countries, it's complete ban. In radio, in television, in online, in offline, or anything, it's all types of advertising, is banned. That's why you can see a decline of smoking, the rates among the youth and children in many other countries. But unfortunately, it's not happening in Indonesia. So in Indonesia, still you can see the iklan in radio, in television, in online media. So there are some restrictions from the new PP, but it's not quite comprehensive. So what we request to all of you here to build really a good advocacy both at the subnational level with the Wali Kota, Bupati, DPR, and also at the national level to ask them to have a complete ban of advertising. I think that is something is not happening in Indonesia. Let's do it. The second, in other countries, as I mentioned, the tobacco tax, the price of tobacco pack is very expensive. It's not, you as a student, you cannot afford it. Very, very expensive. Like a $20 per pack in Singapore, for example. The same tobacco product from export from Indonesia to Singapore. The cost, the price of one pack, $20. Big, no? But you can buy here in $1 or maximum $2. It's very, very cheap. So what we need to do is really to advocate the government to increase the price on tobacco packs. Okay, and then that will help the people to pick up smoking, especially among children. And among adult smoker, if it's very expensive, mahal, right, then it motivates to quit or reduce the smoking or number of cigarettes they smoke. I think that is something, those strategy needs to be in place, which is not right now, it's not in Indonesia. So there are many other places, like a Ministry of Health is trying to push the other ministry to make a good policy in tobacco control. The KTR, smoke-free environment, is also, it's getting better, but we need to do more and more in Indonesia. So in short, Indonesia hasn't ratified the WHO framework convention on tobacco control. It's the only Nagara in Asia, and that hasn't ratified the WHO, the convention, FCTC. All 182 countries already signed and implementing the good tobacco control, but Indonesia is not part of that. I think because of that, the tobacco industry is really trying to get that opportunity, to intervene in the government policies and programs, and there are so many interference from the industry side because there is the FCTC. Indonesia is not a member of the FCTC. So I think that's a very big policy that we need to work together to really convince the national governments to ratify the FCTC. The Ministry of Health is trying its best, but the Ministry of Health needs to get help from the public and from many other sectors for this. So in terms of revenue from tobacco, right, there was an industry claim. The industry is one of the main source of government income or revenue, overall revenue. I think Indonesia is around 9% something of the total cukai, cukai excise. But actually you have to look at who pay the tax. Is it industry or is a smoker? It's a smoker. The smoker pay the tax. It's not the industry. So keep in mind, it's not the industry, they are really making the false argument or they contribute big money. Actually, it's not. The smoker pay the tax and smoker are risked to get disease, both communicable and non-communicable because of the tobacco smoking. And there is a high out-of-pocket expenditure and loss of productivities and a huge amount of money that the Ministry of Health or the health sector, they have to put to treat NCD, for example, jantung, cancer, tuberculosis, many others. So it's a huge cost in terms of health, the health sector. So it's far, the larger than the the revenue that they get from the tobacco. So in other countries, like for example India making really good progress in tobacco control program. Although there are many challenges, but compared to any other countries, very good progress. And the smoking prevalence also going down. It's a huge country, right? It's a billion population and second largest producer in terms of tobacco. But they are doing really good because there is solid government commitments and the public participation. So let's do this, and Indonesia is, we are doing really good as a team. So you all are, as I mentioned, you are the change agent, you can make a difference. My second, the question is about your things is more on the smoking cessation. Of course, there are some resistance, right? But what we see from many other countries, from the evidence, from the research, it suggests that, for example, the TB patient who smoke, they visit health center. It depends on the country context, the program. In some country every week, or some country in every month, some country every 2 months. But they visit to collect medicine, so they have to go anyway. And then you can add when the puskesmas, when the health staff gives the medicine, at the same time they can offer brief advice. As a public health side, our role is to provide information to the smoker, right? It's really up to them how they perceive this. If they perceive it positively, they quit. If they don't, maybe there are some resistance, something. But we need to continue doing that one. Even we can see some dropout, but we need to continue our messaging to the. So regarding the alternative, I think there are 3-4 methodology in terms of helping people to quit smoking. The one is a very brief advice. So it can be provided by anyone like us, or primary health care center, or school teacher, or the friends or family member. The second is more on the quit line. If people wants to quit, they can call to the quit line and get more the extensive information. Like in other countries, for example, in Thailand, the quit line is very, very successful. To help smoker to quit in Australia and even in India, in many countries, and in Indonesia also the quit line is there. But we need to make it more effective. There are some challenges, but the Ministry of Health, I think Ibu Hanifa will talk about that. The third is the pharmacology, because it's an addiction, right? So addictive to the nicotine. So some of the smoker, they may need the additional the support, that is medication. So like in other countries, for example, in Thailand or India or many other countries, the smokers are advised to buy the medicine. Like a pharmacology, there are some recommended medicine by WHO that helps the people to quit smoking. But it's Indonesia, I think the Ministry of Health is working on that. So our strong recommendation is, to the governments and this, the people, the smoker. There are 70 million smokers in Indonesia. So it's impossible to provide the medication to all, right? It's very expensive. But who are really highly addictive, who needs really additional support to quit smoking, I think those can be included within the JKN, the universal health coverage. So to support, to quit, to buy the medicine. I think that is something we can work together to help the smoker. Yeah. Yeah, I don't know.
If they use the additional nicotine replacement therapy, for example, the nicotine patch or varenicline, bupropion, it is related to the TB treatment or something?
Yes, and I can see, the recent report from Philippines. The Philippines is going to add the nicotine patch or the medication to support the TB smoker. So they are going to put within the framework of the Global Fund and also the TB control strategy. So maybe that is also I don't have any information about that. Yep.
Baik, terima kasih Pak Tara. Jadi kalau misalnya pakai patch atau gum itu mungkin tidak ya. Tapi kalau drug, pakai misalnya antidepresan gitu untuk membantu berhenti merokoknya, belum ada bukti sih untuk interaksi obat. Ya, mungkin dari tim kerja Ibu Hanifah atau Ibu Dr. Rina bisa menjelaskan lebih lanjut terkait dengan pertanyaan dari kedua penanya. Ibu silakan, mungkin Ibu Hanifah dulu.
Iya, mungkin tadi sudah beberapa memang betul dijelaskan sama Dr. Tara ya untuk pertanyaannya tadi. Kalau untuk tadi bahwa tadi yang cukai rokok itu memang banyak yang ditanyakan bahwa penyumbang, padahal itu adalah kalau dikaitkan cukai rokok di Indonesia itu sekarang ini adalah 147 triliun, sementara akibat dari rokok itu sendiri hampir 3 kali lipatnya. Kemudian kalau terkait kenapa Indonesia tadi juga bilang dari Pak Tara, kita memang untuk menandakan FCTC itu belum. Namun kalau dilihat dari FCTC itu sendiri, Indonesia tuh sudah memasukkan sebenarnya dalam PP. Jadi kalau dilihat dari komitmen untuk melakukan pengendalian tembakau itu sudah kita lakukan. Di mana nanti mungkin sebenarnya kami mengirimkan PPT kepada panitia. Jadi nanti mungkin bisa disampaikan tadi apa-apa saja pengaturan yang dilakukan oleh pemerintah Indonesia. Jadi hampir sudah ada peningkatan jauh sekali dibandingkan dengan PP 109 tahun 2012. Nah, terkait dengan untuk upaya berhenti merokok, memang di Indonesia untuk farmakoterapi belum dilaksanakan. Namun dengan adanya amanat RPJMN ataupun indikator Rensra bahwa nanti targetnya di tahun 2025 sampai 2029 ini nanti itu adalah sekitar 15%, di mana nanti 2005 atau 3% dari puskesmas yang punya upaya berhenti merokok. Nah, itu nanti untuk farmakoterapinya ini yang digunakan di Indonesia saat ini sesuai dengan rekomendasi dari PDPI itu adalah obatnya berupa nikotin NRT ya, nikotin replacement terapi, kemudian bupropion dan periniklin. Dan memang ini saat ini untuk farmakoterapi ini sudah dilaksanakan di rumah sakit yang mempunyai layanan upaya berhenti merokok. Dan memang kalau secara dilihat secara keberhasilan, memang kalau dengan hanya dengan konseling aja itu keberhasilannya tuh 5-10% atau rata-ratanya di 7,6. Namun kalau dengan adanya farmakoterapi itu akan memberikan keberhasilan itu 35-50%. Apalagi juga nanti kalau di layanan UBM-nya itu ada dilakukan psikoterapi ataupun juga tentu dukungan sosial. Karena juga terapi dengan farmakoterapi obat ini itu memang untuk obat yang diminum itu juga lebih banyak dan memang tantangannya juga justru karena nanti terkait adiksi. Nah, itu juga memang ada hal-hal yang perlu diperhatikan. Jadi memang juga kalau nanti pemberian farmakoterapi ini juga ada pendampingan sebab nanti ketika dia melakukan terapi farmakoterapi ini juga ada efek sampingnya. Misalnya nanti apakah dia nanti ada hal-hal yang mungkin malah dia tidak mau minum obatnya karena merasa ada efek sampingnya setelah dia melakukan farmakoterapi. Nah, ini juga semacam ada PMO juga untuk nanti farmakoterapi dalam UBM. Saya kira itu untuk tanggapannya. Terima kasih.
Baik, terima kasih Bu Hanifah. Jadi sudah semakin jelas ya apa yang ditanyakan ya adik tadi ya terkait dengan tobacco control, terkait dengan FCTC juga dengan cukai rokok ya. Jadi memang sebenarnya cukai rokoknya besar, tapi biaya yang kita keluarkan untuk penyakit akibat rokok itu jauh lebih besar. Ya, mungkin yang kedua, Ibu Dr. Rina ada komentar terkait dengan dua penanya, terutama yang tentang TB treatment dan juga sekaligus dia punya menggunakan pengobatan dalam berhenti merokok. Apakah ada interaksi obat dan mungkin Ibu Rina bisa memberikan tanggap.
Saya sempat terlempar dari Zoom. Jadi mohon diulang pertanyaannya ya,
Baik,
Suarjana.
ya tadi ada penanya yang menanyakan terkait dengan TB, khususnya tentang pasien TB yang mengikuti treatment untuk berhenti merokok, di mana akhirnya misalnya menggunakan salah satu NRT, nicotine replacement therapy, misalnya nikotin patch ataupun menggunakan obat mungkin ya, salah satu antidepresan, mungkin ada nggak efeknya terhadap obat TB-nya seperti itu? Terima kasih.
Ya. Terima kasih pertanyaannya. Jadi selama ini kita sudah memang secara ilmunya saya mungkin perlu melihat lagi, tetapi secara program ini kegiatan antara OAT, pemberian OAT dengan upaya berhenti merokok yang terkait dengan obat, ini memang tidak ada interaksi ya, tidak ada interaksi obat karena ini sudah bisa dilakukan walaupun mungkin saran dari kami ya kalau upaya berhenti merokok ini sebaiknya memang dengan edukasi dulu. Jadi seperti yang saya sampaikan di depan tadi, jadi melakukan edukasi, jadi secara edukasi ya setelah kemudian mereka berusaha menghentikan merokok. Memang ada yang dengan farmakologis kan berhenti merokok, ada yang non farmakologi ya. Nah, kalau yang non farmakologi bisa seperti mengurangi mengurangi merokok misalnya atau mengurangi waktu. Jadi misalnya tadinya jam 1 sehari misalnya 5 gitu bisa dikurangi bertahap. Misalnya jadi 4, jadi 3, jadi 2 outputnya. Jadi seperti itu. Kemudian yang kedua juga melalui jam ya. Biasanya setiap sekian jam itu bisa dihentikan waktunya bisa dilonggarkan. Walaupun sebetulnya kalau niat gitu ya, kalau niat itu kan sebenarnya bisa menghentikan sama sekali. Tapi kalaupun tidak bisa dan harus menggunakan farmakoterapi, kalau semacam patch gitu-gitu, sementara ini untuk interaksi obat OAT itu nggak ada interaksinya. Ya.
Baik, terima kasih Ibu Dr. Rina atas tambahannya. Mungkin semakin lebih jelas ya, Dio ya. Baik, mungkin masih ada waktu di Zoom ya. Untuk pertanyaan di Zoom, we have a question from the Zoom. Ya. Berapa ada pertanyaannya? Banyak banget. Yeah, we have a question from Emma Rahmawati ya. Masih nggak orangnya di sini? Masih ya. Pertanyaannya mungkin bisa langsung terlihat ya. Kok beda ya? Because the increase in conventional cigarette and vapes in school-age teenagers, are school efforts or action in Indonesia for young smokers not effective? Is there an evaluation for school effort for school-age teenage smokers, for example, for elementary, junior, and senior high school? Can you respond? Please, Pak.
I can also respond. Maybe also I would request Ibu Hanifa also to respond it. In general, I think in this room, we all know the harmful of tobacco, right? There is a knowledge, there is a education. So if you also ask the general public, maybe some of them they know about the harmful, but sometimes the education, the knowledge is not enough. So therefore, we need to create an environment where people can think about smoking. For example, in other countries, as I mentioned already, so in Singapore, for example, in Singapore, tobacco products are very, very expensive, and you cannot smoke in any public places. It's a very heavy fine. And the children and youth, they cannot see any iklan because it's all banned, online, offline. It's a ban. And there are very good public, the mass media campaign and public health education, like Gambar, big picture on the tobacco pack, the plain packaging, there are many others. And then there is a comprehensive smoking cessation program in school, and also the quit lines there. It's a very good package. So if you have all the package in place, that would really help to create an environment for the children or a youth or students not to start smoking. If there are some already smoker, there is also the services to quit smoking. So that helps a lot. So in an Indonesian context, I don't want to repeat the same thing. The iklan everywhere, okay? So even you ban the iklan inside the school, but when the children, the youth, they can see when they open their mobile, they can see the iklan roko, right? When they go around, they can see the iklan. Everywhere is a very, very attractive, very, very, the motivational, encouraging. So those industry marketing tactics needs to be banned completely to really reduce the prevalence or smoking among the children and youth. That is number one. Second, cigarettes are very cheap. The student, they can buy, student in a secondary school, they can buy the cigarette easily, and it's available everywhere. And then there is a peer pressure and the environment in a room, in a home, in a family. We have there is no such a barrier. So that's something, the price should be really increased on tobacco pack, and the people can smoke everywhere here. So the smoke-free environment, the smoking should be banned in all public places, workplaces. So if that is the case, then we can build the education in a school and build the school health program to educate the children about the smoking or any other harmful products. So that would help a lot to decrease. If we only do the school health program, but there is no any other public health measures or tobacco control, it doesn't work. It would only contribute to increase smoking prevalence among children and the youth. So it should be very comprehensive. Yep.
Boleh.
Ya, silakan ditambahkan.
Iya.
Atau ya,
boleh.
silakan Ibu Emma.
Ya, biasanya kan memang biasanya di sekolah-sekolah itu kan selalu ada sanksi atau selalu ada aturan ya di awal, atau bagi yang merokok sanksinya bla 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 gitu ya. Yang sebenarnya tegas dan bisa ada sanksi akademiknya lah seperti itu. Nah, itu maksud saya itu apakah nggak jalan atau bagaimana? Apakah itu memang harus komprehensif, iklan dan sebagainya lah, lingkungan harus kita ciptakan. Namun kita melihat sisi sekolahnya gitu. Meskipun mungkin peran sekolah itu kecil, tapi tetap harus kita evaluasi gitu ya untuk penerapan hal-hal yang seperti itu gitu, aturan-aturan yang bisa berbuntut akademik, berbentuk keras gitu. Itu mungkin.
Ya, Ibu Emma, maaf, adik apa Ibu? Ibu Emma ya? Suaranya hilang.
Enggak, udah segitu.
Oh, udah. Mungkin Ibu Hanifah bisa memberikan tambahan terkait dengan pertanyaan Ibu Emma.
Ya, betul sekali. Mungkin tadi terkait untuk di sekolah ya. Jadi sebenarnya dari sisi peraturan dulu dengan adanya PP 28 tahun 2024, memang PP-nya baru keluar hampir 6 bulan ya, dan memang ada waktu perlakuan untuk 2 tahun sosialisasi untuk implementasi PP ini. Namun kalau untuk pasal larangan, jadi memang pada pasal 434 itu kami sudah di PP sudah dikeluarkan bahwa untuk larangan penjualan rokok radius 200 meter. Jadi tadi yang disampaikan Pak Tara, kalau di Indonesia mungkin tidak ada ban total seperti di Singapura, namun di Indonesia kita sudah mengeluarkan aturan bahwa radius 200 meter itu tidak boleh di sekolah ada orang yang menjual rokok maupun rokok elektronik. Kemudian juga pembatasan kalau nanti mereka di luar rumah. Nah, itu juga ada bahwa ada larangan sebenarnya pada penjualan usia 21 tahun, juga pada point of sale itu tidak boleh ada iklan tentang rokok. Kemudian untuk larangan iklan di sekolah juga 500 meter itu tidak boleh ada. Nah, kemudian selanjutnya juga pada tadi untuk iklan di media elektronik. Nah, itu juga nanti kita dengan bersama-sama Kemenkominfo itu akan melakukan take down terhadap iklan-iklan yang ada di media elektronik maupun di media massa, termasuk juga dalam e-commerce ya. Nah, itu juga kita sudah melakukan karena memang saat ini kita tahap sosialisasi ya di 2025 sampai nanti 2026 2027 bulan Juli itu implementasinya. Kemudian sebenarnya juga dengan adanya KTR, kalau tadi ada 361 daerah yang punya perda KTR, maka salah satu tatanan yang wajib itu adalah di sekolah. Jadi itu tidak ada harusnya ada paparan rokok ataupun orang merokok di sekolah. Dan betul sekali sebenarnya hampir di semua sekolah itu sudah ada aturan tentang tata tertib sekolah, tentang siswa yang merokok, kemudian ada sanksinya. Kemudian juga namun kembali lagi pada implementasi di daerah juga tadi terkait perda yang untuk larangan pada di sekolah terkait dengan penegakannya, bagaimana penegakannya nanti di tatanan-tatanan KTR. Kemudian sebenarnya juga secara aktif itu ada kegiatan screening perilaku merokok di sekolah untuk usia 10 sampai 21 tahun. Ini sebagai apa? Bahwa kita juga menyampaikan kepada anak-anak sebenarnya kalau kamu tidak mengakui bahwa tidak merokok, banyak anaknya tidak mengaku merokok tapi sebenarnya dia merokok. Nah, itu kita ada lakukan screening sehingga kalau nanti ditemukan mereka merokok itu akan dirujuk atau dilakukan konseling ke sekolah. Jadi itu sudah dilakukan di mana setiap sekolah puskesmas itu ada 5 lokus, kemudian setiap ada hampir 5.000 puskesmas yang melakukan kegiatan screening perilaku merokok ini. Jadi hampir ada 2.500 kegiatan untuk screening perilaku merokok di mana setiap satu lokasi itu ada 200 anak. Jadi banyak lagi untuk bagaimana kita memastikan kegiatan pemantauan ataupun kegiatan perilaku merokok di sekolah. Selanjutnya juga sebenarnya di kampus. Nah, karena memang perubahannya dibandingkan dengan peraturan sebelumnya atau di Renstra sebelumnya atau di RPJM sebelumnya itu hanya batasannya di usia 10 sampai 18 tahun, namun sekarang sudah 10 sampai 21 tahun, maka tadi betul di kampus itu sudah masuk. Jadi selama ini kan hanya sampai 18 tahun pada sama SMA ya. Nah, kemudian nanti di sampai 21 tahun tentu di perguruan tinggi itu karena sudah ada peraturan yang diutamakan adalah penurunan pada 10 sampai 21 tahun, juga itu dikembangkan kampus-kampus yang KTR dan melaksanakan layanan upaya berhenti merokok. Jadi bentuk sekali memang kalau aturan kemudian hal-hal secara legal itu tidak akan ada maknanya tanpa dilakukan dengan pemantauan ataupun implementasi serta penegakan sendiri terhadap aturan yang sudah dibuat. Saya kira itu tanggapannya. Terima kasih.
Baik, terima kasih Ibu Hanifah. Jadi tambahannya sudah sangat lengkap ya dari Ibu Hanifah. Mohon izin nanti biar nggak lupa nanti kita minta ya Bu Hanifah PPT-nya sama Bu Rina juga ya, Bu Dr. Rina.
Ya, sudah saya sampaikan ke panitia melalui Mbak Laras.
Baik, terima kasih Bu Hanifah. Mungkin itu ya Ibu tanggapan dari pertanyaan Ibu Emma ya, jadi sudah clear. Masih ada lagi satu penanya dari Zoom. Mungkin saya bacakan saja dari dari Miss ya, Rita Widyadana dari S.Ked Media Leader based in Bali ya. Jadi mungkin panitia bisa menampilkan pertanyaannya yang dari Ibu Rita. Jadi pertanyaannya Indonesia TB Elimination Program mostly rely on foreign donors including the Global Fund and USAID, both of which contribute to the success of Indonesia's TB program so far. With USAID possible funding stoppage and the Indonesian government massive budget efficiency, including cutting health ministry budget, how is it affecting the future of Indonesia TB elimination program? Wow, it's a very big question. Not for, it's for Ministry of Health. Maybe mungkin Ibu Rina, Ibu Hanifah, Ibu Rina ya untuk TB ya. Silakan Ibu Rina. Pertanyaan jelas.
Saya udah jawab sebelumnya di chat ya. Jadi memang untuk USAID itu stop 100% ya. Jadi mereka langsung berhenti gitu. Kasihan juga sebenarnya teman-teman kami gitu ya yang bekerja di USAID tiba-tiba langsung di PHK gitu. Bulan Februari termasuk semua pembiayaan yang sebetulnya rencananya salah satunya ada yang sampai dengan tahun 2029. Itu udah berhenti sama sekali. Tetapi alhamdulillahnya Global Fund masih lanjut ya sampai sekarang. Nah, sebagian besar untuk obat, kemudian untuk program-program eliminasi TB 2030, Global Fund itu masih membiayai. Sementara ini kan beberapa tahun gitu ya, sampai 2026 masih lanjut. Nah, mungkin nanti di situ kita membuat perencanaan lagi. Jadi sementara ini masih jalan. Kemudian yang efisiensi ya. Memang sekarang semua efisiensi di Kementerian Kesehatan ya. Tetapi untuk TB ya, untuk program TB karena ini masuk ke quick win tadi seperti yang disampaikan, jadi tidak ada pengurangan. Jadi seperti active case finding itu tetap, kemudian kita rencana-rencana ya untuk penemuan kasus, kemudian untuk pencegahan TPT ya itu tetap. Nah, yang berikutnya kita memang dari secara nasional mendorong ya dari kabupaten, provinsi dan kabupaten kota untuk membuat budgeting sendiri kan dari daerah itu karena TB itu bagian dari rapotnya kabupaten juga ya karena Kemendagri itu juga concern KTB. Jadi diharapkan kabupaten dan provinsi itu membuat budget juga terkait program TB dan ini juga banyak ya banyak daerah-daerah yang mempunyai program tersendiri seperti di Banten gitu. Saya kira Bali juga membuat program juga ya untuk melaksanakan. Ada beberapa juga membeli portable X-ray sendiri gitu. Kabupaten atau provinsi itu untuk melaksanakan active case finding ya. Seperti itu. Jadi 3 itulah pendanaannya. Demikian.
Baik, terima kasih Bu Dr. Rina. Maybe you have.
Yeah. So I'm not talking about the Global Fund and USAID, but I think for sustainable program, whether it's a tobacco control or tuberculosis or any other public health program, always for any country they need to identify the domestic resources. I think that is very important to sustain the program, you know. So I think this time is a really unique opportunity for many countries who used to receive the USAID and other, you know, the funding. What can be done? Like a win-win. The first thing, the governments, like especially maybe the Indonesian, the governments can increase the tax on tobacco product, can increase the tax on alcohol, can increase the tax on SSB, like sugary drinks. And these all are the very harmful products. And their only consumption, you know, creates the disease only. There is no any benefit of smoking. There is no any benefit of alcohol drinking. There is no any benefit of SSB, sugary drinks and all. So government is a perfect opportunity. They can increase the tax and use the tax money to support the TB control program, to support the tobacco control program or JKN or any. So I think we need to find the ways, you know, there are win-win. If a tax increase, what would happen? The smoking prevalence, the smoker, you know, maybe the prevent smoking and also help to smoker to quit. That helps what? Reduce the disease burden, you know. So it's a win-win situation. Let's tap this opportunity, catch this opportunity to increase tax and price on tobacco and other harmful products.
Thank you, Pak Dara. Maybe I want to hear also from the Epicet Media, Mr. Bobby Ramakan. Do you have any experience or sharing about this issue? You still join?
Yes, I'm here.
Yeah, please, about the Indonesia Future Program in Elimination TB regarding the fund.
Yes, I think I will totally echo what Dr. Tara Singh Bam has just said. I think this is very, very important to have sustainable health and development programs, and of course, looking domestic, tapping upon domestic resources is so important. And Dr. Tara Singh Bam's statement is also important because what he is saying is evidence based. So one of the WHO scientifically proven approach which has shown to very strong public health outcomes in so many countries is raising taxes on tobacco. And of course, why only tobacco? And he's very right that to using the same approaches which have proven to advance tobacco control without any cost to the government, like raising taxes. It has very strong public health outcome in terms of not only deterring people from using tobacco, but also protecting our children and young people so that they are not able to get tobacco at a lower price. So I think raising taxes is really important, and we need to use these lessons to leverage upon address other issues also, like for example alcohol and or other sugary drinks, for instance, he has said. And of course, like fast food industry, like all the industries which are making products that are directly linked to harming public health of our people. I think those should be very highly taxed. Secondly, I think it is very important to understand that we as people we need to push for more more accountability of our subnational leaders, national leaders, that the budget prioritization is for the people. I think so. Where are we spending? So, is it because, for example, on tuberculosis, for every $1 spent, the scientific evidence shows there is $46 as return on investment. So, is it not a smart investment? It's a smart investment. It is not spending, it is investing in population. If we do good TB control and tobacco control or end tobacco, I will like to say what Dr. Tara Singh Bam, I'm sure, will agree, is a super smart investment, because not only you are helping your strengthen your TB program outcome, but also your NCD program outcome, also environment, and so many other benefits for the population when it comes to the health and development. So this is very important to Dr. Tara Singh Bam is seeing the silver lining in the dark cloud of, because USAID and other US funds which have stopped have really been a very serious issue in so many countries. But the point here is the silver lining. This is an opportunity to act, and will totally echo what Dr. Bam has said about looking inwards, making sure our programs now onwards are more sustainable, more dependable on, and if it is possible to sustain them on domestic resources, I think that will be really very important in the short and longer run. Thank you so much.
Thank you, Mr. Bobby Ramakan, for your sharing. Bagaimana panitia? Masih? Ini kita sudah lebih 15 menit ya, adik-adik, Bapak Ibu. Masih ada nggak penanya dari audiens di sini? Karena berapa ya ada merchandise untuk? Ada berapa? 3, 4, 5? Ada berapa?
Ada 5, Dok.
Oh, ada 5. Masuk baru 2 keluar. Atau cukup? Ada penanya lagi? Ya, silakan. Oh, lagi 1 aja dah. Ya, the last but not least ya. Sebelum kita akhiri. Oke, nama dan dari mana, Adik ya?
Baik, terima kasih atas kesempatannya, Dokter. Perkenalkan, nama saya Igustayumas Anini Cenindewi. Saya dari instansi Stikes Binausada Bali. Saya ingin bertanya, menurut Dokter Tara, karena sekarang sangat banyak sekali remaja yang menggunakan rokok elektrik, apakah dengan menggunakan rokok elektrik tersebut akan berdampak terkena tuberkulosis, dan bagaimana upaya untuk memberikan edukasi kepada para remaja tersebut yang sudah ketergantungan? Terima kasih.
Yeah, I think it's quite clear. Understandable. Oke, pertanyaan sangat bagus ya dari Ayu dari Stikas Bina Usada ya. Jadi we forgot about the electric cigarette related attributable to the TB. Yeah. And then also the how to educate them from the addiction from the electric cigarette. Please.
I think this is very great question, but I don't have an answer now. So there is no such a evidence at the moment that suggests, the e-cigarettes and its impact to TB. But in general, there are many evidence that if a vaping or e-cigarette products, these products are harmful to health. So that's evidence already exists in now. So from our side, as a public health, we do not encourage e-cigarette, and it should be banned, like many countries ban. For example, in our region, in ASEAN, the Singapore bans already, the Cambodia ban the e-cigarette, the India ban the e-cigarettes. So many countries, ban the e-cigarette because they are harmful to our health. So there are multiple health the impacts. So I think that is something our clear position on this. But the industry, the vape industry, they come up with it's a harm reduction, less harmful. Less harmful means it's still harmful, right? So it's a harmful product anyway. Yeah, that's our position. Ibu Ayu, would you like?
Ibu Ayu has updated about this question.
Mungkin menambahkan juga nanti.
Ya, saya rasa posisinya sama ya dengan sampaikan Pak Tara. Memang kalau dibandingkan dengan merokok dan rokok elektronik, bukti yang kita miliki terkait dampak berbahaya dari rokok elektronik itu jauh lebih sedikit ya, karena keberadaannya juga baru ya, jauh belakangan dibandingkan merokok. Tapi kalau kita lihat, sudah banyak bukti yang menunjukkan kalau menggunakan rokok elektronik itu juga menyebabkan kerusakan pada saluran pernapasan termasuk paru-paru. Jadi karena kita tahu tuberkulosis yang paling banyak itu adalah tuberkulosis paru. Jadi dalam kondisi normal aja tuberkulosis itu akan jauh lebih mudah berkembang gitu ya ketika kita memiliki kekebalan tubuh yang menurun. Jadi sama halnya ketika sudah terjadi gangguan kondisi paru itu akan memungkinkan risikonya, tapi memang belum ada studinya. Mungkin jadi PR nih ke depannya yang harus distudi ya. Tapi benar yang disampaikan terkait klaim harm reduction yang saya rasa mungkin di kalangan anak muda, harm reduction ini sekarang kan mungkin memberikan iming-iming gitu ya. Oh ini lebih aman nih untuk dikonsumsi. Makin banyak anak-anak muda yang baik yang perempuan maupun laki-laki juga mengkonsumsinya. Tapi yang seperti yang disampaikan tadi, produk ini tidak bebas risiko. Jadi tetap memberikan dampak berbahaya bagi kesehatan. Sudah mulai terkumpul buktinya. Jadi posisi kita mestinya sebagai orang kesehatan dan kesehatan masyarakat tidak menyarankan orang untuk beralih dari rokok ke rokok elektronik ataupun mencoba menggunakannya. Sedikit tambahan, terima kasih.
Baik, terima kasih Dr. Ayu ya.
Boleh menambahkan?
Oh silakan Ibu Hanifah.
Ya, jadi dari Kementerian Kesehatan juga memang betul yang untuk harm reduction ini memang dengung-dengungkan para industri rokok khususnya rokok elektronik. Jadi Kementerian Kesehatan menyatakan bahwa dengan adanya rokok elektronik yang diklaim sebagai tobacco harm reduction ataupun diharapkan bisa menurunkan ini adalah karena rokok elektronik sama bahannya dengan produk tembakau, di mana sebenarnya di rokok elektronik itu tersendiri tidak hanya memang berbeda dengan di rokok konvensional. Nah untuk rokok elektronik isinya adalah ada nikotin, kemudian nanti tentu sama-sama menyebabkan adiksi, kemudian ada nitrosamin atau TSNA itu yang menyebabkan karsinogenik, kemudian glikol dan gliserol itu menyebabkan iritasi saluran napas dan paru, kemudian ada aldehid, formaldehid, ini menyebabkan inflamasi paru dan karsinogenik. kemudian ada acrolein atau lated dan naphthylamine itu menyebabkan karsinogena, juga ada logam dan heavy metals di mana ini menyebabkan inflamasi paru, jantung iskemik, kemudian kerusakan sel dan karsinogenik, serta partikometer atau inflamasi paru, jantung dan sistemik serta karsinogenik. Dan juga makanya pada PP 28 itu sendiri definisi rokok itu tidak hanya sampai rokok konvensional tapi juga rokok elektronik. Jadi sama-samanya dilarang, bahkan untuk rokok elektronik juga sudah ada peraturannya ataupun aturannya di mana nanti tentang isinya, kemudian bagaimana kemasannya itu juga sudah diatur dalam PP. Jadi kalau saat ini didengungkan oleh industri tentang harm reduction itu tidak betul sama sekali.
Baik, terima kasih Bu Hanifah atas tambahannya. Bu Rina perlu? Bu Rina ada tambahan Bu Rina? Bu Dokter Rina? Tidak ada ya, jadi pas ya. Jadi demikian ya, ayo ya. Jadi memang penelitian yang disampaikan tadi oleh Pak Tara itu terkait dengan merokok konvensionalnya dengan TB. Jadi untuk karena dia baru untuk elektrik sigaret atau rokok elektronik ini, jadi belum ada penelitiannya. Tetapi bahayanya juga tetap sama, ya. Perlu ada penelitian lebih lanjut. Jadi baik, terima kasih untuk sudah. One final comments, please.
Yes, just a few seconds. My request to all of you, the young leaders here. So you, as I mentioned earlier, you are the change maker. You are leader. You are the solution for our community. Please, my request is don't participate any industry donation activities. That means, please do not take any donation from the tobacco industry, from alcohol industry, from Coca-Cola, from Pepsi, all, because the industry donation always is for what? They want to position their product, they want to make their profit. So that is my sincere request to all the young leaders here, and also to the University of Udayana. I'm sure the University of Udayana is already tobacco-free universities. So hopefully the Udayana doesn't accept any donation from tobacco industry and other alcohol industry as well. Like there are many other industry in Indonesia, University of Erlangga completely banned any type of donation, sponsorship, and the advertising from the tobacco industry. Great job. Udayana has done the same thing. University of Indonesia has done. All the Muhammadiyah University in Indonesia, they also ban the donation, everything they don't receive. So what I mean is we need to really isolate tobacco industry, and they are not our friends and they are not our enemy. But what we need to do is we have to regulate them and isolate them from the activities. So that's really important, because otherwise at this point, I already hear from many the officials and the partners that the industry would like to give some money to support public health program, especially, for example, tuberculosis, since USAID has stopped. Not only in Indonesia, many other countries. But the industry vested interest, their hidden interest is to make profit. They don't give free of charge, right? So we have to stop those donations. Instead, what we need to do, government has to increase the tax, increase the price, and use that the excise tax revenue for implementation of tobacco control, TB control, any other public health issues. So please, need to really isolate tobacco industry. No collaboration, no coordination, no donation from them. Yeah, thanks.
Thank you, Batara, for the closing remark, the key message for all of us in the university, because so many university. Baik Bapak Ibu, we come to the end of the guest lecture. Jadi kita sudah memasuki ya penutupan ya, adik-adik, Bapak Ibu, baik yang di Zoom maupun di luring ya. Saya mengucapkan ya terima kasih yang sebesar-besarnya, terutama for our distinguished speaker, for your valuable lecture today, and also juga Ibu Hanifah dari P2 PTM dan juga Ibu Dr. Rina ya dari tim kerja TB Kementerian Kesehatan, and also Bobby Ramakan from S.Ked Media. Thank you very much for your sharing, sir. Oke. Dan teman-teman di sini juga adik-adik dan Bapak Ibu, terima kasih atas partisipasinya. Tadi ada beberapa pertanyaan yang sangat menantang memang ya, challenging question, so many ya. Jadi itu menunjukkan bahwa adik-adik Bapak Ibu ya semakin concern terhadap pengendalian bahaya merokok sekaligus juga mengendalikan tuberkulosisnya ke depan. Ya, baik akhir kata, saya sebagai moderator atas nama speaker Dr. Tara dan juga responder mohon maaf apabila ada kekurangan selama penyampaian guest lecture ini, dan saya tutup dengan Paramasanti. Ya, Om Santi 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 Om. Wassalamualaikum warahmatullahi wabarakatuh. Salam sejahtera dan salam sehat untuk kita semua. Ya, selamat siang untuk semua. Aplaus lagi untuk Pak Tara dan para responder and me also. Yeah.
Oke, sekali lagi kasih tepuk tangan yang meriah ya untuk moderator kita dan our guest speakers. Oke. Okay, thank you, Dr. Suarjana and Dr. Tara, and also for our three responders that sharing such a valuable insight for us from the morning until afternoon, right? And I'm sure we have gained so much knowledge and understanding from these sessions. And okay, for the next agenda is presenting merchandise to active participant during the discussion sessions. Then to the following names. Please come to the stage, okay? And wait. Okay, for our moderators and our speakers can have a seat, okay? Oke, jadi untuk teman-teman yang namanya I Gusti Ayu Putu Mutiari Dewi bisa naik ke atas panggung, Dio juga bisa, dan juga yang terakhir I Gusti Ayu Mas Andini Cahyaning Dewi. Oke, bisa maju ya. Dan saya juga mengundang Doa Ayu untuk pemberian merchandise-nya. Oke, jadi sayang sekali ya yang bergabung online itu tidak bisa kita berikan merchandise-nya, ya. Oke, mungkin Dr. Tara you want to... Oke, mungkin Doa Ayu aja ya. Oke. Oke, kasih tepuk tangan yang meriah gitu nafas.
Tadi jauh-jauh.
1, 2, 3. Lagi sekali 1, 2.
Oke, kasih tepuk tangan lagi yang meriah untuk ketiga pertanyaan kita hari ini. And ya, jadi disinilah kita sampai di penghujung acara ya. Jadi untuk para teman-teman terima kasih atas kehadirannya. Mohon maaf apabila ada kekurangan kata atau salah kata pada saat pelaksanaan ini. Saya juga Intan mewakili seluruh panitia mengucapkan terima kasih dan mohon maaf apabila ada kesalahan selama penyelenggaraan acara. Dan tidak lupa di sini sebelum meninggalkan ruangan, teman-teman, Bapak Ibu yang sudah hadir pada hari ini bisa dimohon untuk scan barcode supaya mendapatkan sertifikat dari kami. Oke, jadi jangan lupa diisi absensinya bisa di scan barcode di layar berikut. Untuk teman-teman yang ada di Zoom mungkin juga bisa, tadi sudah dikirimkan ya link oleh panitia via Zoom dan juga bisa di scan juga barcode-nya. Terima kasih. Okay, ladies and gentlemen, we have to come to the end of this event. I hope you all have enjoyed this guest lecture, and I would like to thank you to our organizer and all of you for your participation and support. And I wish you all the best in your futures endeavors, and hope you see you again in our next moment. And don't forget to follow our Instagram at Udayana SPH, yeah, if I'm not mistake, to know more information about us and also for the next guest lecture. Okay, thank you so much and have a great day. And we also prepare a lunch for all of you, so you can go to the registrations area to get the lunch. Thank you, everyone. Have a good day.
Ya kita waktu itu